Hello, friends and colleagues. I'm Manoj Karmakar, your host and the convener of the ISSPS 2021. It gives me great pleasure to welcome you to the International Symposium on Spine and Paravertebral Sonography 2021. I trust you and your loved ones are well and in good health wherever you are in this wonderful world. During this educational festival, renowned opinion leaders, teachers, researchers, and experts from around the world and locally will discuss the most updated information and emerging trends in this state-of-the-art field of region anesthesia and pain medicine and beyond. I can promise you, and irrespective of whether you are a novice or an expert practitioner in this field, you will not be disappointed. As the convener of the ISSPS, I'm also most grateful to the faculty for accepting my invitation. I bring you greetings. I bring you greetings from Hong Kong and hope someday very soon you'll be able to visit our wonderful city. We are coming to you live from our studios at the Prince of Wales Hospital at the Chinese University of Hong Kong. This is one of the two medical schools in Hong Kong. The university is not very far from the Prince of Wales Hospital, and if someday you are in our vicinity, we will surely like to show you around. Today's meeting is being organized by the Department of Anesthesia and Intensive Care of the Faculty of Medicine, Chinese University, and it is part of the 48th anniversary celebration of our university. I'd like to take this opportunity to thank Payung for supporting us in bringing this live webinar to you. Payung has been at the forefront of innovation in the field of region anesthesia and the pain medicine by bringing us many innovative products that we use on a day-to-day basis. If you are interested to get in touch with the representative, you can either log into their website or contact your nearest representative for any of the products that you may be interested in. I'm proud to announce that today we have close to 2,600 registrants. They are slowly logging in. We have about 250 so far, but I'm sure by the end of this session, there will be a lot more. This is the distribution of where folks are from. As you can see here, not only from the Americas, but also from South America, Africa, majority from Asia, Australia, New Zealand, including the Great Britain and Europe. These are the countries that have more than 50 participants. Australia, China, India has Indonesia, Philippines, Thailand, and the United Kingdom. I think this figure shows you, table shows you that the victory of how we can now communicate over the net with folks that we may never have done in the past. These are the people that have registered from far as South America, Bolivia, Peru, Ecuador, Venezuela, Bolivia, Brazil. So I welcome you all to the ISSPS 2021. This event is also very special because it happens to be the 10th anniversary of the ISSPS. We started way back in 2009. To the right of this image, you will see the first book that we published on this topic at about in 2009. This book has grown to quite a voluminous book today, and I will come to that in a moment. These were some of the faculty opinion leaders who started off this journey that we started in 2009. A person really worth mentioning is Dr. Thomas Grau, who was a visionary in this field of ultrasound and spine and his interventions. Today, he's far from the field of anesthesia, but nevertheless, he has left a legacy behind that we all hopefully are carrying on. Today, I'm joined by three very distinguished gentlemen, researchers, teachers in this field of ultrasound and musculoskeletal imaging, if you may. Professor Bernhard Moriggl, to the top of your image, comes from Innsbruck in Austria, from the University of Innsbruck. He's from the Department of Anatomy. All I can describe in a nutshell is that he is as big can be in anatomy. He has been a mentor to many of the opinion leaders of today in this field of region anesthesia and pain medicine. He's extensively published. He's spoken at numerous meetings around the world, and his cadaver workshops at Innsbruck is par excellence. So if you're looking for a meeting where you can attend a par excellence cadaver workshop, I can highly recommend it because I have been there. The next is Professor Miguel Angel Reina. Professor Reina again needs no introduction. He's from the University of Ciudad San Pablo School of Medicine in Madrid, Spain. He's also an adjunct professor at the University of Florida in Gainesville, United States of America. His work in the field of microanatomy is par excellence. Again, it's unparalleled. It is, his work has really opened up many areas in our specialty that we talk about today. It has changed our practice and the way we look at anatomy and sonoanatomy. He's again very well published. His atlas in microanatomy is something that every one of you in this meeting today should be in possession of. Dr. Kenneth Sheah is indeed a diagnostic radiologist with a very keen interest in pain medicine. Dr. Kenneth Sheah comes from Singapore. He is a well-known teacher, extensively speaks at many radiological and diagnostic imaging meetings. He has published extensively in the field. And today he's going to share some of his insights into the topic of discussion with respect to CT and MRI anatomy. I welcome you three to this meeting. But before I get the proceedings going, I have a few housekeeping things to take care of. First is, do remember that the next event will be 2 weeks from today. It'll be on the 28th of August, webinar number 2, and we will be discussing about ultrasound for epidural and paravertebral injections in the thoracic region. Now, this is a webinar. So the attendees, as attendees will have limited privileges, but there will be a Q&A at the end of this webinar. So in order to put your questions forward, please use the Q&A function in the chat function. Via the chat function, you can ask the question. When you ask a question, please address it. Please do mention to whom, which of the faculty the question is addressed to. Thereafter, please put your name and location down so that we can also address that. Now, because there may be many questions and time is limited, so we have assigned a moderator who will pick some of the interesting questions out of the lot. And if you make the cut, the questions will be asked on your behalf by the panelist. Finally, this is some reference material, books that you may find useful in this field of region anesthesia and pain medicine, particularly for interventions that are ultrasound guided in anesthesia, as well as pain medicine. And many of this are actually going to be discussed during this webinar series. Okay, now, without further ado, can I now request Professor Bernhard Moriggl to start the proceedings as our first or opening batsman, if I may say that. Welcome, Bernhard.
Thank you, Manoj, for all this very fruitful information on your Very unique event, and I'm more than happy to have joined, and I hope we will learn a lot all together during this series. So, my topic is relevant anatomy, of course, also functional for central neuraxial blocks, plain and or regional in the lumbar area. If you see this guy, it seems easy. If we come from outside, inside to the vertebral canal at the end. First of all, palpation, and let me point out that position and status of the thoracic spine is equally important to understand position and or alterations of the lumbar spine. And of course, we have to do dynamical investigation and or inspection. So it's very important and very notable that any change of posture of the human body will change the course and topography of the spine as a whole, and especially of the lumbar spine. And even in young individuals, as you see here, you may have scoliosis, and that makes it more difficult, but definitely you will not have any problems in palpating spinous processes, etc. But we have worse cases, that means severe scoliosis, etc. I'm not talking about pathology, but show you 2 or 3 slides as a representative to compare with the so-called normal. And of course, we all know obesity is a problem. And as you see, it's easy to palpate, for example, in the thoracic spine processes, but it may be very, very difficult to find landmarks, osseous landmarks in such individuals. And of course, ultrasound helps you a lot because your orientation is almost always possible or even excellent. So we start with an image where on the right-hand side, you see removed erector spinae muscles. On the left, everything is intact, including the thoracolumbar fascia. And this is an example where we probably go to the spinal canal, and we will come from outside skin and go and end up in the intrathecal space. A cross-section shows you if you go through the midline, you have to cross a lot of ligament stuff. And if you come from paramedian in an oblique way to go to the epidural space, it's completely different. So skin is the same, but then instead of ligaments, you have the thoracolumbar fascia and then the whole mass of erector spinae muscles. We will show everything in detail in the sequel. So I start with osseous, important osseous anatomy, and we have to talk about the interspinous, interlaminar space, of course, the spinal canal boundaries, and what I call the interarticular notch. It's not in the official terminology, but you will see it is of utmost importance. If you look on a spine from posterior in black, you see marked the spinous processes, but keep in mind, they are not one above the other in a straight line always, even in very normal vertebral columns. As seen here, number 4 is displaced, and this is important, palpation, sonography, etc. So if you palpate spinous processes, do not expect them one above or below the other. That's just normal anatomy. And if we talk about the interspinous space, it's clear in lordosis, as seen left-hand side. They are rather narrow, especially in the upper part, and you can get rid of lordosis and open those interspinous spaces easily in healthy persons, not always in pathological conditions, but there are other ways, as you will see. So position, posture is absolutely important. And keep in mind also, there are variations, that's not pathology, where you have drop-like extensions, caudal extensions of the spinous processes. And this makes the height and accessibility through those interspinous spaces to the aim, which is the vertebral canal, more difficult. And a huge number of variations exist in the so-called lumbosacral transitional zone. And you need a lot of experience to get them right, but again, sonography will help you in clarifying this. And we're also talking about the interlaminar space. And this interlaminar space is best seen as in the middle part of my presentation in a posterolateral view. And this is exactly what you do if you go with your sagittal ultrasound orientation from outwards inwards. And keep in mind also a lot of not variations, but starting pathological conditions may occur, especially in the transition zone to the thorax, because as indicated with our red arrow, you have a lot of ossifications, and not so rarely you will have them in the ligamentum flavum that we have to discuss in detail in a sequel. And now let me introduce the so-called interarticular notch. And you see a difference between the lumbar spine, bottom right, the thoracic spine that we will discuss in 2 weeks, and we will not, or I will not discuss that, but you will discuss that in the sequel of the series, the webinar, the cervical interarticular notch. All of them are different. And this is a key to understand how wide are the windows that you get, for example, to use ultrasonography. And the thoracolumbar transition zone is important. If you see TH11, 12, and this would be lumbar vertebra 1, you see the opening, that means the access to our vertebral canal is pretty okay. It's very much comparable to the lumbar spine per se. So that's a good thing to get the knowledge about this. I don't go into details because it's not for our access directly, but just to remind you that the transverse processes of TH11 and 12 are completely different to 10, 9, and above. So it's clear that the vertebra try to get similarities to the lumbar spine. And now you all know the phenomenon of the kissing spine, and you see the spinous processes touch each other, and there's no access in the median to the vertebral canal. And because there's also alteration of the facet joints, you see an inferior articular process almost pushing to the neck of this so-called Scotty dog. That means the access through the interlaminar space is very narrow. But fortunately, you will find, especially with sonography, there are windows to be accessed. So use it in combination with your clinical picture. And as said, this is no longer lumbar, this is TH12, and very common. You have ossification of the, we call it yellow or ligamentum flavum. And the more you go to the thoracic area, the higher the number of ossifications. That's a phenomenon. Ossification of the ligamentum flavum in the lumbar area is less frequent than in the thoracic. We will discuss that in 2 weeks. A typical L2 vertebra, to understand what's the boundaries as far as from the osseous side, you see the vertebral arch, the pedicle, and the lamina that fuses from both sides to the spinous process. And of course, the posterior aspect of a vertebral body. But I may remind you that in the lower part of a posterior aspect of a lumbar vertebrae, there is no osseous boundary, because if you put two together, you have your big intervertebral foramen. And as you will see, the boundaries of this is also done by one important structure that we have to discuss. It's the ligamentum flavum. Again, I indicated this because this is clinically important. That's the so-called interarticular portion of lumbar vertebra. That's important because there's almost no sponges material inside, and that is prone to fracture. And now what's the difference? L1 to L4 look pretty much as my typical example from L2, but L5 is so different. And that makes it that our vertebral canal is from the shape completely different. And if you have a picture of a cross section of the sacral canal in mind, it resembles that. It gets narrower, and from this form and shape got almost triangular. And the articular processes are very close to the osseous borders of the spinal canal. a little bit in contrast to L1 to L3 and 4. So after having seen the osseous part, we go to the ligamentous part. It's supraspinous, intraspinous, and of course the ligamentum flavum. Supraspinous, you have seen this picture, but now from a different aspect. You see the supraspinous ligament covers those spinal processes. And again, as I said, this is 1, 2, and so forth. They are not exactly one above the other. Here, yes, 5, 3, 4. So keep that in mind. And the thoracolumbar fascia. We cannot talk about the supraspinous ligament without mentioning the thoracolumbar fascia. And as you see in the detail of this cross section, that's a functional unit. And in a few minutes, you will see other ligaments do the same. Building functional units, not isolated structures. The next is the interspinous. Of course, if you see from posterior, not so well seen, you will see that in a second. And the ligamentum flavum that is removed here where the needle is inserted to show in the deep area, the dural sac that will be the last part of my presentation. And in this schematic illustration, this is a real bone, and this is what I did to illustrate the important things. That is the massive interspinous ligament. It's so strong, and it starts here. That means it produces artifacts in ultrasound, almost as bad as osseous structures, especially if there are alterations to this ligament. And the ligamentum flavum that spans between true laminae and more, as you will see, because attachments are not so well known to everybody. And here in this example, you see a gap between left and right ligamentum flavum. This is not always the case. Whatever is the case, the gap is always closed by the interspinous ligament. And if you do a cross section, strictly lateral to the median, that means a few millimeters, you get this incredibly beautiful image where you see vertebral bodies. This is the vertebral canal. Everything is removed to show the yellow or ligament or ligamentum flavum. And now keep in mind that from posterior you have the interspinous ligament between spinous processes, a very thick and massive ligament of collagen. In contrast, the ligamentum flavum is elastic material, and it comes from the upper border of a lamina of the lower vertebrae. And this is now important for ultrasound. It does not attach to the next higher in the same area. It attaches to the inner side of the lamina of the next higher vertebra. That is important. That means almost half of the ligamentum flavum that you see in ultrasound is the lower part, and the more cranial part is not seen at all. But it is an important landmark. Same seen here in the lower segment. It comes from the rim of the lower lamina and goes to the, again, inner side of the next higher lamina. That is important. And see how massive this ligament is. And this is why I can easily see it with ultrasound. And this is also not so well understood. A lot of people think these white lines represent the ligamentum flavum. If you have heard what I said, that's not possible, because this attaches to the outer side of the lamina. And as seen in the cross section just a few seconds before, it goes to the inner side. That means this part of the ligament is not visible with ultrasound. Again, it is a good landmark to go to the epidural spaces, you will see. Now, details on the ligamentum flavum. This is a view from inner side outside. That means we have removed body, just the vertebral arch. This is the pedicle. That's the transverse processes. And you clearly see, I mark it here, that the ligamentum flavum comes from the upper rim of the lower lamina and goes again to the inner side of the next higher lamina. And this is not so well known. It extends far laterally and also attaches to the pedicle of the next vertebra, not only the lamina. This is why it makes border of the intervertebral foramen. And as you see, there's a little gap, there's a bigger gap here, and these are not so uncommon. And generally speaking, the more caudal you go in the lumbar spine, the less frequent will these gaps be. These are a few morphological examples. You see the ligamentum flavum, gap more caudally, a gap throughout, and a very broad gap. That may have a tremendous influence on your approach. If you go to the median, have big gaps, and you don't really feel a loss of resistance by going there, quite in contrast to the paramedian approach. And now you have seen this picture. Now in detail, this, what I marked here, is the ligamentum flavum. That's the last one between S1 and L5. And you see how massive this is. Of course, it's understandable because functionally speaking, it's the most loaded part between sacrum and L5. But there's a direct continuation and attachment to the interspinous ligament that also covers part of the lateral parts of the spinous process, and the supraspinous ligament. And as I've pointed out, it is a functional unit with the thoracolumbar fascia, very thick aponeurotic stuff in the lumbar area. And now I think you can easily understand that all of these ligaments make a functional unit. You cannot have changes of the one without influence, functionally speaking, to the other. And here is the epidural space in this part, in the lowermost part of the lumbar spine, very, very little and narrow. And this speaks for itself. That's a beautiful image ultrasound between S1 and L5. And you see this very, very thick structure. And this is the ligamentum flavum, the last one between L5 and S1. Why don't you see anything in the deep area? This is because of the steep inclination of that ligament in that area. If you want to see the ligament clearly, you cannot always see the other parts of the epidural and intrathecal parts, in contrast to the more upper part of the lumbar spine. And this is a typical example of a lumbar area cross section, and you see the epidural space, and importantly it continues laterally to the paravertebral space through the so-called intervertebral foramen. I myself always call it intervertebral canal, because especially if you go more caudal, it's not a foramen, it's a real true canal. By the way, this is an illustration where we filled it with blue ink, and you see it continues outside to the lateral area. That means also to the paravertebral area. This is part of the Cauda equina, and typically the more caudal you go, the more posterior will those filaments of the Cauda equina be located. As an overview, you clearly see this is the whole lumbar spine, this is sacrum, and the epidural space gets narrower and gets narrower. And in a minute I will also explain the position of the spinal cord. And importantly, you see that it's filled with fat, and blue or dark dots, that's veins. That means that's the posterior part of the venous plexus in the epidural area. And again, you may easily visualize this epidural space by respecting this is the ligamentum flavum and this is the dorsal dura in the upper part of the lumbar spine. And as seen here, you see a lot. And this will be the last picture I explain in detail. And in 2 weeks, I will also go detailed into the anatomy of the thoracic spine, just to remind you that in the thoracic area, the vertebral epidural venous plexus is massive. And in the lumbar part, it's far less prominent. Of course, you beautifully see also here the combination of epidural through foramen through the paravertebral area. And as I said, not everything is beautiful. This is obviously an aortic spine. You see a huge pathology here in the distal area, but you also see bleeding and subarachnoidal bleeding. But I want to point out also in the lumbar area, you clearly see veins from the plexus, and the subdural or epidural, fat and connective tissue is seen in combination with the intervertebral canal. This would be a ganglion, one of the lumbar ganglia. And you clearly see asymmetry. So this spine is typically not in order or in normal shape. You see the transverse process, we call it coastal process, and nothing like this here. There's asymmetry. but still you have the huge, massive ligamentum flavum, which in this case is closed. There's no gap, and that directly could lead you to the epidural space. Again, despite pathology. And this is another example, same individual, lower segment, last one, and you see the ligamentum flavum, and there's massive bleeding inside of the intrathecal area. And in contrast to the ligament, you have lamina here. Again, massive asymmetry, and you see the changes of the whole bones. That's not normal bone. And you also see fatty degeneration of the muscles if you go, for example, through the erector spiny part, but the lumbar, the superficial layer of the thoracolumbar fascia is beautifully seen still. A little few words on the neonate and the first 2-3 years of development in the human. You see, open the epidural space, and I tried to simulate with this little kind of fluid that fat, and that is functionally important, is fluid under normal temperature. That means in the living, it's not as you see it in the cadaver, it's fluid. That means it's an ideal protection of the dural sac, and the dural sac itself with its filled spinal cord fluid is the next protection for the spinal cord itself. And as seen here, I did it in a magnification. That's a wonderful preparation where you also see it's not only fat, it's also connective tissue strands. But the difference to the adults is that the epidural space in the neonates and first 3 years is tremendously bigger, and dimensions are greater than in the adults. And this is a beautiful example where you see development has not stopped. That's a lumbar vertebra, and you see the epidural space, and this is fat and a lot of connective tissue strands. And here's the dural sac that we talk about now. The dural sac in the adult, late 3 here, and it ends at S2 level in most cases. Be aware of the fact that there's tremendous variability in both kids, neonates, and adults, but that's the more or less the room. And you see protection from dorsal, it's osseous, then you have the epidural space, we remove the fat, you have the dural sac, and it ends here at S2 level. Importantly, functionally speaking, the dura has a clear architecture that was described as early as in 1929 by Titus von Lantz, and it exactly follows the needs, the mechanical needs that we find in the individual. And only in the part near the median, you will have strict longitudinal collagen fibers. Everything else is a beautiful architecture that resembles function. And you see the dural cuffs extending laterally. Also very, very different in different levels and very different in individuals. The dural sac in neonates, it ends as S4, and this is important, as you know, if you do a caudal. And again, variability is the law of life. It may differ over 1 or even 2 segments. And the spinal cord ends at L4 in the neonate, and the subarachnoidal space, that means the intrathecal space, is of course as long as is the dural sac. And as I said, the spinal cord ends at L4 in neonates in most cases. And last but not least, let's go intrathecal. You see a beautiful cross section where you see it's a higher level, it's the thoracolumbar junction. You see the spinal cord with its covering, that's the pia. And between dura and pia, there's a remarkable structure, that's the denticulate ligament. You see that also in cross sections. And these are the rootlets, and it is between anterior or ventral and posterior rootlets of a spinal nerve. And important, you see that in magnification very beautifully. It's a saw-like ligament, and that's collagenous stuff that combines pia mater with dura mater, and that gives a separation on one hand. And on the other hand, it is mechanically so important because it keeps the spinal cord in position. So you can say the spinal cord is like in a swimming pool, and in this is protected by fluid. And importantly, you all know that the anastomosis is longitudinal to supply the spinal cord, but keep in mind and have a look at one of those filaments. Every little rootlet has its own vascular supply. That is important, functionally speaking. And you also see there's more than just the denticulate ligament, there's also separations. And the following speaker, I think, or the following two speakers will point that out in detail. So there's more than just one ligament, intrathecal. And to close up, we have come from outside and have ended up in the vertebral canal and in the intrathecal area or the dural sac. Let's do it the other way around. Not so important for a posterior approach, but even visible is the posterior longitudinal ligament, a very narrow anterior epidural space. The next layer would be the ventral dura. Then you see the intrathecal area with the Cauda equina. You see the posterior dura. You see the epidural space. And last but not least, our key landmark ligament, which is the ligamentum flavum, as mentioned. And we started osseous. Of course, you see the acoustic shadowing created by two laminae, one above the other. And by doing this approach, you have beautiful access to all of these parts, epidural or intrathecal, etc. But keep in mind the anatomy. Keep in mind that anatomy is different from L1 to sacral canal, and you can appreciate that by using ultrasound. That was it. I thank you for your attention. And remember, if you do your job, do it seriously. Really. But don't take yourself too seriously. And I hope you will have fun in the next parts of that webinar.
Thank you, Bernhard. That was a wonderful presentation. I think you've got the ball rolling and have really set the stage for more things to come. I think the next speaker, ladies and gentlemen, that I've introduced to you is Dr. Miguel Reina. He will now dwell into the areas of microanatomy related to the neuraxis. If you're ready, Miguel, please share your screen and go. You are live.
I thank Manoj Karmakar for his invitation and this opportunity to share with you all. I am an anesthesiologist interested in the microanatomy applied to regional anesthesia and pain medicine. Good morning and good afternoon. This is a 3D reconstruction from MRI in normal patient. At the lumbar spine, there is a real epidural space filled by fat where we perform the lumbar puncture, and a virtual epidural space located anterior to vertebral lamina. The fat thickness would allow the epidural space to be identified with a minimum 10 effect in experienced hands. But unlike the cervical spine, there is no epidural fat, and it is necessary to produce a 10 effect. Supraspinous and interspinous ligament and ligament flavum are crossed at median approach, but supraspinous and interspinous ligament with a thin thickness similar to a spinous process are prevent in paramedian approach. This is a ligamentum flavum from anterior view. Two portions are fused in the midline. The effect in this fusion gives rise to gaps on the midline. From a posterior view, you can see as ligament flavum fills the entire interlaminar foramen and extends to the articular facet. A paramedial approach will always cross the ligamentum flavum. We can check the variation of the ligament flavum thickness in sagittal cross-section. Both portions of the ligament are at 45 degrees. In a paramedial approach, the path traveled by the needle tips is lesser compared to a median approach. A slight toward cranial inclination will increase the thickness travel, increasing the sensitivity perceived when ligament is crossed. The thickness is not uniform. Commonly, they are asymmetric between left and right ligament portion. Just to 1 to 2 millimeters offset from the midline help to cross a thicker ligament flavum during epidural techniques, offering a safer technique. We can see the gaps between the left and right ligament flavum portion. Above and below ligament flavum, we observe the vertebral lamina. The needle must always pass through the ligamentum flavum that fill the interlaminar windows. The epidural fat is the main component in the lumbar and sacral spinal region. This is the distribution of epidural fat at lumbar region. It is important to highlight that the posterior epidural fat at lumbar region, but the posterior epidural fat is found at the same level than the ligamentum flavum. As you can see, the thickness is greater in the midline, and there is not fat ahead the vertebral lamina. We can check from anterior view of dural sac. The fat is located on the lateral places. The friction of the dural sac on the posterior longitudinal ligament during flexo-extension movement of spine decreases its growth and makes the passage of epiduroscope through the midline more difficult. What is the easiest way for a solution injected into the epidural space to extend cranially, caudally, and circumferentially? This will be the pathway that offers the least resistance. The pathway will be epidural fat. The injected liquid will go through paths that's open between the adipocytes that will be separated by the force of the injected volume. The higher injected volume and injection speed will reach a greater solution spreading. Different factors will affect the cranial, sacral, or circumferential spreading, such as the greater or lesser amount of fat, the negative thoracic pressure, the diameter of the intervertebral canals. Here we see several pathways open within the fat toward the intervertebral foramens. During an epidural injection, part of the injected volume is spread outside the spine through path that's open through the thickness of fat between the muscles. This spreading of solution can also occur in reverse direction, entering toward epidural space after injecting large volume between muscle close to spine in certain peripheral anesthetic block. Now the intraspinal ligament inside dural sac. This is the dorsal arachnoid septum or ligament posticum. These ligaments are inside the dural sac within the subarachnoid space, justify unexpected result and insufficient spinal block due to inadequate circulation of cerebrospinal fluid. Here, the denticulate ligament is always present, and other intraspinal ligaments like this broad posterolateral ligament extending from right to left with a rare bubble shape, occupying the posterior spinal subarachnoid space. Here we can see the dorsal arachnoid ligament, ligament posticum, extending on the midline along the entire dural sac, divided to liquid posterior compartment. A ligament like this one may alter the final outcome after perform an spinal anesthesia. Analyze the dural sac. This is the external surface of spinal dura mater. The collagen fibers are at random direction, but not in longitudinal direction and parallel among them, as we read in some books. The elastic fibers are at random direction too. Here, the elastic fibers. This is a sagittal cross-section of spinal dura mater. This is the dura mater, and this is the thickness of the arachnoid layer. The dura mater is formed by around 80 concentric dural laminas. Here, the epidural space, this is the acquired subdural space, and here, the subarachnoid space. Each dural lamina is formed by interlaced fiber at random direction. This is a strong membrane, but permeable membrane. It is not actually a pharmacologic barrier. Here we can observe the arachnoid layer, the dura mater, and acquired subdural space. This is epidural space, cerebrospinal fluid, and cauda nerve roots. Arachnoid layer is the true pharmacologic barrier of dural sac. This one is the dura mater, and that one is the arachnoid layers. This is the ultrastructure of arachnoid layer formed by arachnoid cell that govern the passage of drug crossing dural sac in a transcellular passage. All molecules administered into epidural space must cross the plasmatic membrane and cytoplasm of this cell to reach the subarachnoid space. The degree of the liposolubility of molecules is an important factor in this passage. Does the arachnoid trabeculae have any interest for you? Arachnoid trabeculae form sleeves. The arrows shows arachnoid sleeve enclosing the cauda nerve roots. Arachnoid sleeve in red limit a small compartment surrounding the nerve roots, filled for cerebrospinal fluid too. Outer, the arachnoid sleeve is the main pool of cerebrospinal fluid. But if by accident the local anesthetic volume is partially injected inside an arachnoid sleeve, the injected concentration is not diluted as always it is done, and toxic effect over the nerve is achieved. Here, nerve root, the arachnoid sleeve local anesthetic molecule within the rational sleeve and within the main pool of cerebrospinal fluid. Clinical doses of local anesthetic will be a toxic doses when it was injected inside the arachnoid sleeve. Here we check in our lab if this event may be possible. Arachnoid sleeve is translucent and allows us to see the needle orifice inside the sleeve. This event is possible and it could justify some neurological complication as Cauda equina syndrome and radicular transient irritation syndrome have performed a normal and clear spinal anesthesia technique. Here the full axial cross-section of dural sac, including all Cauda equina nerve roots. Here motor and sensorial nerve roots, sacral nerve roots. Sacral nerve roots can be reached during a lumbar puncture when we perform a middle approach. The paresthesia is a probably event when we perform a lumbar puncture. If the medullary cone in orange is reached and intraneural injection were performed, surely the patient will develop major neurologic complication as a permanent paraplegia. There had been report of a permanent paraplegia after punctures between second, third lumbar vertebra level approach as a result of anatomic variation at the site of the end spinal cord. Here the tile of the axons within Cauda equina nerve roots. Myelinated axon within Cauda equina nerve root at more magnification. Here we can observe the axon, the myelin, and the endoneurium. But what happens when our patient feels a paresthesia? This one may occur using our spinal needles in our patients. This lesion may occur during a paresthesia after performing a spinal anesthesia, but this patient in general does not suffer a clinical evidence of this injury because nerve function is ensured by thousands of axons. This nerve root of Cauda equina seen in the pictures could have at least 80,000 myelinated axons, and only around 500 axons could be affected. Now you can see what happened in an unintentional subdural block. This is a typical spreading of contrast solution in an unintentional subdural block under X-ray. Symptoms are atypical and different in each patient because for some reason and now until now, the spreading was asymmetrical. In this event, the spreading may be in A, within the subdural space in blue, or in B, within subdural in blue and epidural space in red. Curiously, it does not produce a circumferential spreading throughout the entire dural sac as would be expected, but it will be necessary to know more about the subdural space to better understand this complication. But what is the subdural space mentioned so many times? The subdural space actual does not exist anatomically. Between the innermost dural lamina and the arachnoid layer, there is not a space, but this space is occupied by a tissue formed by neurothelial cells, star cell types that are very fragile, and when they break, they form a bubble that's enlarged, making a new space acquired at that time of very variable extension. Injection of a solution within the thickness of the dural sac can give rise to this acquired space. The extent of this space will depend on the injected volume. Please check this image. This is the entire thickness of the human dural sac. You can see there is not any space between dura mater and arachnoid layer. Anatomically, subdural space does not exist. This is an acquired space. Above, there is not any space between dura mater and arachnoid layer. But below, in this sample, there is a space between dura mater and arachnoid layer. This space is an acquired space. This space is not circumferential. This space is limited and only appears where neurothelial cells has been broken. This justifies why the clinical symptoms of these patients are so different, because the local anesthetic may have a different spreading and, of course, asymmetrical spreading. These are the star cells responsible of the origin of acquired subdural space when they are broken. This is a three-dimensional image of these cells. There are few specialized shantions among them. The broken occur always in the neurothelial cells and never in neighbor tissue as dural lamina or arachnoid cells. The subdural compartment is a low-resistant place. Analyze the complication. The dura mater is more rigid and the arachnoid layer is more elastic. After a large TEN effect, a piercing of dura mater occurs. The needle pushes and detaches the arachnoid layer, creating an acquired subdural space. A catheter could also be introduced, but we consider will be necessary to check this possible event. After checking this possible event in our lab, effectively, this complication is possible, and we confirm that despite its size, an epidural catheter could enter inside subdural space. This opens a window to the knowledge of this complication and to be able to understand different clinical symptoms that occur in our operating rooms. Now we will talk about the lumbar puncture and dural lesion that justify the origin of post-dural puncture headache, PDPH. These are spinal needles, bevel quinque and pencil point spinal needles. These are the tips of these needles. Traditional hypotheses so far read in many anesthesiology textbooks. Currently, we know that the diagram is not right. The dura mater is formed by fiber at random direction, as we saw in previous slide. And most important, there are two superimposed lesions, one in dura mater and another in arachnoid layer formed by cells. And the last one is the most important. Here, this lesion produced by 22 gauge quinque needle in first attempt, aligning the bevel parallel and perpendicular to the axis. the lesion areas after 20 minutes to withdraw the needle were same. The shapes of the lesion produced by a beveled needle and another by pencil point type are different, but the open area of the lesion is similar. After using a beveled needle, the edges of the lesion are cleaner and more continuous. Again, after using a pencil point needle, the edges of the lesion are more torn, more irregular, more broken. In this old lesion after a lumbar puncture, dura mater lesion closed first and later closed the opening of arachial layer lesion. We can see the event partially open orifice in arachial layer already occupied by dural laminas of dura mater. The arachial layer is more important than dura mater in the mechanism of the closure of this orifice. The arachial layer closes later and is the one who controls the leakage of cerebrospinal fluid. As we have seen before, the arachial layer is formed by cells. It is not formed by fibers. The cells do not have any kin of a ligament. The ligament of the beveled needle has no foundation. This old recommendation currently has no value. And you can observe altogether different lesions produced by different needle capture at same magnification. Compare yourself the hole and the needle used to better understand why headache occur. We recently published in Regional Anesthesia Pain Medicine the evolution of the closure of the dural sac lesion in a sheep model, and we showed that the natural healing process of the dura arachnoid lesion produced by a twig needle is not linear, but logarithmic, with only 65% closure of the puncture hole at 7 days. Probably around 35% of the lesion is even open in our patient when disappear the symptoms. Why do we have fever headache after to use the pencil point needle? Traditional hypothesis related to separating the fiber and avoiding their breakage or false. After 2-3 collisions against the bone, an unpredictable new design will be produced after to use a beveled needle time, and the needle will lead to more large injury. But this event does not occur after to use pencil point needle because its tip does not deform after hitting the bone even several times. Well, and now only to say thank you. You all send Professor Karmakar, and this is our email if you contact with us. Thank you for all.
Thank you, Miguel. That was an exceptional presentation with wonderful images. I'm sure the participants have taken away some useful images that they can relate to. Now, from the anatomy of the dead, let's go to the anatomy of the living. So now it gives me great pleasure to welcome Kenneth.
Okay, thank you very much, Manoj. Let's start with my presentation. Trying to share my screen. This aside. Okay. Right, I'm Kenneth Sheah. I'm a radiologist, but I also do ultrasound guided injections in the lumbar spine. So this is a eminently relevant to me as well. And I thank Miguel and Dr. Bernhard for their excellent lectures. I also want to credit my other friends who've helped me on this journey. Dr. Edzo, a radiologist who's presented at ISSPS before, Dr. Victor Chi, who is a fantastic anesthetist, and of course, Manoj himself. And I'll be showing you some images, trying to build on the giant shoulders of Dr. Bernhard and Miguel with images of the lumbar spine on CT and MRI. So we're going again from dorsal to ventral, and we'll talk about the osseous anatomy, what we can see on our imaging, ligament anatomy, the dura, the meninges, the spinal cord, and then we'll mention a little bit about the subdural space. So firstly, with CT scan, you can get really thin cuts, sub-millimeter, usually 0.6 millimeters, and then you can reconstruct that into sagittal and coronal images. But what's really in practice are the axial images. And so I'm going to show you some real-life images here. So this, you can see, is an axial image of the L4 vertebral body. We just take this as L4. And usually you get this scout image, okay? So you don't get a nice sagittal reconstruction usually when you're trying to do, say, CT-guided injections. You have to use this and a red line to tell you where you are in relation to the vertebral body. Now, remember what Dr. Bernhard said, the pedicles are attached on the superior aspect of the vertebral body over here. And that's why when you see us doing, say, vertebroplasty or lumbar augmentation procedures, the needles usually take an oblique tract along the transpedicle route from superior to the inferior portion, like that, because of the location of the pedicles. So on this axial image, we can see the spinous process. We can also see the laminae of the lumbar spine and then the transverse processes as they come down on both sides. This is the L4 spinal canal, the bony margins of the spinal canal, and then the vertebral body. You can see the erector spinae muscles, and they're defined by fatty strands within the intermuscular as well as the intramuscular spaces. Note the orientation of the pedicles in an oblique projection. And now we're moving slightly below the pedicle. And now you see the appearance of the exit foramen. So this is the level of the exit foramen below the pedicles. You will still see a little bit of the spinous process if you're scanning directly perpendicular to the floor, as we do with the CT scanners. So the spinous process follows down into the lamina, and then from there, the appearance of the exit foramen with the nerve root not seen at the moment. That's the vertebral body. Spinous process, lamina. Come down one more level, and then you start to see the appearance of the facet joints. And you are now in the interspinous space. So on the top here, if we follow Dr. Bernhard's lecture, this is the supraspinous ligament, and then it flows down into the ligamentum flavum, the two limbs of the ligamentum flavum as they traverse the interlaminar space, and then the facet joints over here, and then the disc level. So at the disc level, this is a very characteristic appearance. We are right over the intervertebral disc here. It's dark, there's loss of bone. You can see some margins of the bone on the side, but the nucleus pulposus is dark because it is not calcified. Coming back again, you can see the ligamentum flavum, the thick limbs of the ligamentum flavum, the small epidural space in the back here, and then the spinal canal containing the spine, the thecal sac, and the CSF. So there is potentially, if on a CT-guided injection, a space where there is no traversing bone through which you can place a needle in the midline, straight down between the two limbs of the very tough ligamentum flavum into the epidural space to get an epidural injection. We move down again, one more level, now at the superior end plate, you're starting to see the nucleus pulposus disappear, the superior end plate, and showing you the inferior articular process of the lumbar vertebra above, L4, and the superior articular process of the lumbar vertebra below, L5. And these form the facet joints. And now you start to see the spinous process appearing again. So that window, that interlaminar window or interspinous window is very small. And it gets even smaller as you go higher up in the lumbar spine, where you see the lumbar lordosis reducing the interspinous distances. Again, you see the spinal canal at the L4, L5 level here. Superior articular process. And now we come back down to the level where we started, the spinous process, the laminar, the pedicle of L5, and the transverse process over here. And you can see as how triangular that spinal canal shape is now compared to L4. So always bear this in mind as you're doing your cases. Now, not all our patients come to us with CT scan, and most of them will have some kind of MRI before we do any intervention. Now, let me just quickly orientate you with regards to the different sequences on the lumbar spine. The important thing here is to pay attention to the fluid, the CSF signal around the spinal canal, around the spinal cord and the cauda equina nerve roots. If it's bright, then we call this a T2 weighted scan, which means it's weighted along the T2 properties of fluid. So fluid is bright. And you can see the urine within the urinary bladder being bright as well. Now, a T2 scan also picks up fluid within fat cells. And that's why you can see that fat within the subcutaneous tissues around the viscera of the abdomen and pelvis is bright as well. A T1 weighted scan is the opposite. The fluid around the spinal canal and within the spinal canal, around the spinal cord and the cauda equina is dark. And the urinary bladder signal is also dark, but fat signal is bright. Okay, so the key to recognizing what sequence you're looking at is fluid. Pay attention to that. T2, this one is T1. And if we want to be we want to focus down on fluid signal alone, we will then apply a fat suppression sequence. In this case, an inversion recovery or a stir sequence. So this gets rid of the signal from the visceral fat and the subcutaneous fat, as well as signal within the marrow itself, bone marrow fat, leaving us with nice signal within the discs, allowing us to pick up desiccation within an intervertebral disc, allowing us to detect bone marrow edema or modic type 1 end plate change in the paravertebral end plates, which may independently be pain generators themselves. It also allows us to analyze the degree of disc protrusion, and it is well contrasted against the CSF signal within the spinal canal. So then I ask you, what is this last image? The signal of the fluid is dark, but everything else looks dark. Bladder, dark, subcutaneous fat, dark, but there are these bright areas here, and these are the basivertebral veins, and these are vascular structures which are now bright. And the only way we can get that to happen is if we give them contrast. So this is a post-contrast T1 weighted fat suppressed scan. T1 weighted fat suppressed contrast scan. Okay. Now, again, the most relevant for us is the axial anatomy. But before we go there, remember that you can, like Dr. Bernhard said to us, you can get scoliosis. So you always have to bear this in mind. But remember the very oblique and inferiorly projecting course of the nerve roots as they come, as they emerge from the lumbar spine exit foramina. And this separates the lumbar spine anatomy from the thoracic spine anatomy as far as nerve root course is concerned. And we'll speak about that in 2 weeks' time. But for now, just remember that the lumbar nerve roots take a very oblique course inferiorly. And so if you put a needle beneath a pedicle here, you are in a relatively safe space than if you were more inferior and lateral, because then you run the risk of your needle coming into contact with the nerve root itself. Now on to the axial scan itself. Here, let me just take you through the sagittal very quickly. The supraspinous ligament, the spinous process, we're in the midline, and then that space there is subtended by the interspinous ligament. Before that, then you come through into the very tough ligamentum flavum, and then the epidural space, which usually contains fat. Now, what do we see on the axial scan correspondingly? Here is the tip of the spinous process. Remember that sometimes the MRI axials don't completely register accurately with the sagittals. For some reason, there's always a little bit of a shift. So you have to build a mental model internally. But here's the tip of the spinous process. And you come down, you can see that whole dark unit of the ligamentous unit, the interspinous ligaments flowing down into the ligamentum flavum on both sides, the two beautiful thick limbs of the ligamentum flavum. And then the facet joints, the top of the facet joints just emerging, and the transverse process over here. Sorry, let me just revise that a little bit there. Okay, and then we're moving downwards a little bit. Now, just below the pedicle where we were again, you can see the nerve root coming in. This is very medial, and the nerve roots are still very safely tucked away deep to the facet joints over here, still protected. The lamina, and then the spinous process over here. Coming downwards a little bit now at the disc level, you can recognize that appearance again. Just invert that CT image I told you about. This is fluid within the disc, the annulus pulposus, and then the nucleus pulposus, and then the annular fibers, which are devoid of fluid surrounding it. Look at the ligamentum flavum, again, at the level of the facet joints, and the nerve roots just about emerging now inferiorly. Now, the sagittal anatomy is also important for us to go through before we perform any of these injections. You want to identify the pedicles first. Remember how the pedicles are attached to the vertebral bodies on the superior half, leaving a large notch down here for the nerve root to emerge. And we're now at the level of the lamina itself, and you can see that the inferior articular process and the superior articular process of the facet joints forming a facet joint over here. Now, here's a very real world limitation of MRI. Sometimes the images are cut. The cuts that we get are too thick. It doesn't allow us to see through the interlaminar space as clearly as you would with an ultrasound beam. Remember, the ultrasound beam is at most about 1 to 2 millimeters in thickness, whereas with the MRI scans that we get, this is already 3 millimeters, which already, with one pass, would easily cover the interlaminar space. So you don't always get a perfect image. And here you see it has jumped from just about lateral to the interlaminar space directly onto the spinous process and in the midline, where you can see the spinous processes here, the supraspinous ligament, interspinous ligament, and then the epidural space right here in the midline. Okay, so this is real world stuff. You don't always get picture perfect images, but it's worthwhile to go through them to identify how much space you have to maneuver. Now, I draw your attention superiorly now, because at L5, the canal is slightly narrowed and tapered down, but as you go slightly higher up, you get more and more space within the spinal canal. The epidural space increases in size, and you can start to see the dura and the arachnoid layers coapted together to form the nice boundaries of the thecal sac over here. Beyond this is the spinal canal. So epidural space, dura, and arachnoid, and then the subarachnoid space, where you would be performing a spinal tap, for example. Remember, the conus medullaris is usually terminating between L1 and L2 levels. And that's why people are now increasingly considering performing safer spinal taps lower down in the spine at L4 and L5. But this in itself presents challenges, which we will discuss in a minute. For those who want numbers, the epidural space is usually around 7 millimeters wide in the midline, in the lumbar region, but then it starts to narrow down inferiorly as well. Okay, and now I just want to shift us to the MR workstation, try and see if we can identify some images there. Just give me a second. Okay, I have two images here to share with you. And now you can see the MRI side by side. This is a 39-year-old patient, and the 39-year-old patient has a large lumbar disc which has extruded inferiorly and caudally. And you can see how it's starting to deform the spinal canal. And this needs to be borne in mind if you were to perform any spinal procedure. A deformed thecal sac is not one where you would want to place your needle in, because the anatomy is completely distorted. And the assumptions that we make during paravertebral and central neuroaxis sonoanatomy can be distorted along with it. So you have to be careful. So now, if you can see, I'm scrolling down the axial scans. This is 5, 4, 3, 2, 1, and then T12 level. At T12, the spinal canal is nice and cylindrical, round in shape. The tip of the conus medullaris and then the cauda equina nerve roots starting to emerge. Scroll downwards again, and you can see the spinous processes, the lamina, the transverse process, and the pedicle. This is at L1 level. Still very circular in shape. Scrolling downwards again, the exit foramina start to appear together with the facet joints. So when you see facet joints appearing, you can be fairly sure that you are at the level of the exit foramina if your scan plane is parallel to the disc. And that's a very big if, because in ultrasound, sometimes we can have some cranial caudal tilt of the probe, and that can distort the axial plane as well. So it's important while you're going through the MRI just to build a mental picture of what the whole thing will look like on ultrasound. Slowly scrolling down from L1 down to L4, that central canal is still relatively rounded, and you can see that there. At the level of the L4, L5 disc, let's watch what happens. That anatomy is completely distorted now. Now, this is a diseased disc segment, and what's happening is there's going to be increased stress on all the other supporting structures around the central canal. At that segment level, you see ligamentum flavum now buckling up, and some people say hypertrophied, but it's usually more a buckling of the ligamentum flavum at this level. And you can see that the central canal is no longer circular or round, but more like L5, where it is more triangular in shape. And this is a distortion in the usual anatomy of the central canal. That's the lamina. And if you look at the interlaminar space over here at L4, L5, this is where you would want to approach if you were to go in with a needle in the interlaminar space at L4, L5. There's really not much space there. If you came in from the side of the distorted thecal sac, you might have to enter even more horizontally. Otherwise, you would end up directly into the disc itself, which is a possibility. So it's important to bear in mind as well what the anatomy looks like at diseased levels, and best to try and avoid those if you can. And then now go back to L5, and you can see everything sort of restoring its natural order around central canal over here. But at L5, the bony margins of the central canal are triangular, as Dr. Bernhard showed us. So once again, running upwards just very quickly to show you guys this. Once you're at the level of the transverse processes, you are usually at the level of the lamina. But once you go upwards and you start to see facet joints, you're usually at the level of the exit foramen. Okay, we return to the lecture now. Okay, so remember, there's a major pitfall here in that when we look at lumbar MRI spines, the axials are performed parallel to the discs. When we are doing our lumbar sonoanatomy, the cranial caudal tilt of the probe may not be exactly the same as the lumbar axials as well. So just so I have a good mental image of where you're going. Now, you can also get into trouble when you're dealing with patients with who have degenerative spines. One of the things is there's loss of intervertebral disc space as well as the interspinous disc heights. There's almost no space between the spinous processes over here. And you can see how that epidural space is also very narrowed because there is also generally loss of fat in an older individual. So compare a 52-year-old with a 36-year-old spine. You can see that the epidural space gives you much more room for maneuvering compared with an older individual. So that brings us to a question of what dry taps in spinal anesthesia. So as I showed you, you want to go slightly lower than L2 level because you want to avoid the conus medullaris. And Reynolds suggests to use the lowest palpable level. So usually L4-5 or L5-S1. But with these levels, you get a 10% incidence of dry tap. And then you usually get more successful if you go up one level after that. Why is that? The reason is this, right? The volume of the CSF declines as you go lower down the lumbar spine. At L4 and L5, you've really got a small amount to play with. And so as you go backwards one level, you increase your chance exponentially of getting CSF. Be careful as well because the spinal canal and the thecal sac have different shapes at different levels, as we mentioned. At L3-4, it looks a bit more oval. L4-5, it starts to become a bit triangular and about 10% smaller than L3, L4. So you only really have about L3, L4 and L4, L5 to play with if you were to avoid the conus medullaris. The other problem is that we perform dry taps. We perform spinal taps with the patient in lateral decubitus position. And so if the needle is non-dependent, so you're inserting it from the non-dependent portion into the spinal canal, then the CSF has to fight against gravity. And so you now have a combination of anti-gravity flow and a distorted shape. So don't make your life more difficult by going at a level where there is problems with a degenerate disc, for example. The question is then, if you use a larger gauge needle, would you potentially cause more distortion of the thecal sac as you enter, or are you safer doing it with a small gauge needle? On to the topic of subdural space, and we're coming to the end of this talk. Now, remember, the dural matter and the arachnoid matter are very tightly coapted, and you only have a potential space unless it's been damaged, and then they delaminate. So you cannot resolve the two spaces on a normal MRI or CT scan. But if you perform an injection, and this is under fluoroscopy, and you can see puddling of contrast, but it does not follow the nerve route out into the extraforaminal spaces, be very careful because you might not be in the epidural space anymore. Or as Dorothy says, we're not in Kansas anymore. And following this paper, reported in 2007, a CT scan was performed, and you can see layering of the contrast within this potential space. It does not flow anywhere because if you remember, the dura does follow the nerve roots a little bit towards the exit foramen, but then they fuse with the epineurium of the nerve root. In other words, they don't flow out into the extraforaminal spaces, like we'll do with the epidural space. And that's why you can see gathering of contrast just in a dependent part of the spine, for example. It does not even have to be dependent, because as Dr. Miguel has shown us, the subdural space is not a complete space, and it's just a rent in and causes a rent in the between the dura and the arachnoid, which results in a potential space which can be filled by this contrast fluid. In an epidural, successful epidural injection, you can see the fluid within the epidural space. Here, it's clearly deep to the fat of the epidural space. It's somewhere deeper in, so it has to be subdural in location. If you had a successful epidural injection, an interlaminar approach down here, you would see that this triangle filled with contrast and spilling across and dissecting circumferentially around the dura, and sometimes also following the nerve roots outwards. And that is an epidural injection. So if you're not in an epidural space, then you can only be in two other spaces: spinal, which is intrathecal, or the subdural space. And with the spinal injection, if you were to give anesthetics, you end up with a Cauda equina blockade or saddle anesthesia. But with subdural, it is unpredictable. Number one, the effects may not be fully apparent for a few days even. You can make the pain even worse. Then patients may have spinal headache, and some people say it may predispose to arachnoiditis. So the key here is that subdural contrast, as opposed to intrathecal, appears more opaque, and it stays there if you were to perform a fluoroscopy guided injection, because you'd have no CSF dilution or runoff in the subdural space. It just gathers there. So the other tip I would give you is, if you withdraw the stellate from say a 22 gauge needle, and you see CSF coming back as well, because you can get CSF leaks in the subdural space, then stop, right, and reposition the needle to get back into the epidural space. And that's the only way I think that we can tell on a ultrasound based injection technique. So just to quickly summarize, I wanted to show you the real world MRI and CT anatomy, as well as the limitations that we face in assessing the interlaminar space, especially. And remember that the MRI cuts are much more thicker than our ultrasound beam itself. The ultrasound is only 1 to 2 millimeters. The MRI cuts usually about 3 millimeters, 4 millimeters in thickness. But have these landmarks in mind when you're doing your ultrasound. If you see transverse processes, you're likely to be at the pedicle level. If you see the facets, you're likely to be at the foraminal level. The lumbar nerve roots run in a inferior and caudal oblique course. The interlaminar space is seen between the facet and the transverse process. And if you encounter a dry tap, then go up one level. If the stellate shows CSF, stellate withdrawal then reveals CSF, then withdraw gently, reposition for an epidural injection. And that's the end of my talk. Thank you.
Thank you, Kenneth. That was a wonderful presentation. It truly complements what Bernhard and Miguel had spoken earlier. And I'm sure for the participants, it was truly I can't describe that. I don't have a word. It's a festival where you have seen anatomy in different prospects, in different aspects of the lumbar spine. Okay, now we have a short break here because I'm sure there's a lot that has gone in the last hour and a half or so. We are a little ahead of schedule, which is always good because we are always behind schedule. So we are about 7 minutes ahead of schedule. So we're going to have a 15-minute break here. So ladies and gentlemen, go find your best preferred beverage or whatever you would like to do. And we will see you in 15 minutes time, where we will talk about ultrasonography of the lumbar spine and the interventions that we do and how we can how we can make it, how we can best use it in our clinical practice. So go away and don't go away. We'll be back in 15 minutes. Thank you. Hello, welcome back. After the wonderful 3 presentation by Bernhard, sorry, just a moment, Bernhard, Miguel, and Kenneth, I think it has set the stage for us to better understand some of what we do using ultrasound for these neuraxial procedures. What I'm going to do is in the next 25 minutes or so, I'm going to talk to you about ultrasound imaging of the lumbar spine and how you could use it for central neuraxial blocks. In the second half after that, I would dwell into some of the technical aspects of how to perform central neuraxial blocks using ultrasound with the knowledge that we have all acquired now. So in the first part, I'm going to talk about sonoanatomy, the ultrasound imaging techniques, and how you could use it in clinical practice. I have no conflict of interest to declare, but whenever you see this red star, it usually means it's an important take-home message. So if you take home a few of these, I've done my job. So let's try and get as many home as possible. Now, when you look for ultrasound for central neuraxial blocks, it is actually an integral part of our clinical practice. We do it day in and day out. And when you look at its historical considerations, it was Leonard Corning and August Baer in the 1800s who actually described epidural and spinal injections, respectively. There was some debate whether Corning's injection that he claimed was indeed a spinal, but actually he never reported any fluid emerging from the end of the needle. So his was considered an epidural. The August Baer's was indeed a spinal injection. Central neuraxials today are the gold standard for obstetric anesthesia. Success depends on your ability to identify the epidural or the intrathecal space. You rely on surface anatomical landmarks to identify these landmarks and then perform the neuraxial intervention. Anatomical landmarks are useful, but as Bernhard mentioned, that variation or variety is the spice of life, if you may. Variation is very common, and they vary among patients. And more importantly, it's difficult to identify these landmarks before needle insertion. And identifying these landmarks in the obese can be very challenging. Also, when you look at the current methods of identifying the epidural space, i.e. we use loss of resistance or the free efflux of CSFs as our endpoint for epidural and spinal injection respectively. Loss of resistance is a blind technique. Failure rates vary from 5 to 7%, and complications, although rare, still continue to occur. Actually, if you look at the reported incidence, this is a large retrospective cohort of patients where they looked at about 20,000 neuraxial blocks in the obstetrical population. You can see that there is an extremely high success rate of about 95 to 98%, and the failure rates are low. And this is exactly what you do, ladies and gentlemen. However, we seem to be quite happy when you have a spinal anesthetic failure of about 5% and you convert them to general anesthesia. And the retrospective data suggests that there is a low rate of complications, even dural puncture. This is another major audit that was conducted by the Royal College of Anaesthetists, and they looked at the incidence of complication. They found that the incidence of major complication was rare after central neuraxial blocks. And when they occurred, they're usually transient and very rarely. And they said that the most optimistic rate of serious complications are actually less than 1 in every 100,000 neuraxial blocks. So that's an extremely low incidence of complications with the landmark-based technique. Now let's take a look at how accurate is your ability to identify a given landmark using palpation. In the early 2000s, there were a number of investigations where investigators looked at your ability to identify the given lumbar interspace using palpation when compared with ultrasound, CT, or MR imaging. Cumulative data suggests that palpation is very inaccurate. You correctly identify the spaces only about 30% of the time. There's a tendency to identify an interspace higher than you intend, and accuracy is often affected by obesity. And higher up the lumbar, higher up the spinal column you go. So that means if you're trying to identify a specific lumbar thoracic interspace, you're probably never going to be correct unless you use some alternative methods of identifying the space. So therefore, the intercrystal line that we all anesthesiologists are taught and we have grown up to use during neuraxial block is actually not a reliable landmark for neuraxial anesthesia. So since we are talking about spinal sonography, I think it would be apt to ask this question, is there a role for ultrasound? Actually, when you look at spinal sonography, it's not something new. Spinal sonography has been used in the field of diagnostic radiology since the 1980s. And it's been used in neonates and infants as a first-line screening test for spinal dysraphism, detecting tumors, vascular malformation, etc. It's understandable because it's not possible to take these young children into the MR suite or put them into a gantry. Also, when you look at ultrasound imaging of the spine in the neonates, Professor Moriggl illustrated very eloquently in one of the cadaver images, and you can see that because of the incomplete ossification of the posterior elements, you can see, as you can see in the ultrasound image to your right here, you can see the neuraxial anatomy very clearly. Therefore, it can, in fact, supplant CT and MR imaging. And in fact, the diagnostic sensitivity is comparable to an MRI in these young babies. But that's not the case in adults. What about in adults? Actually, it is quite interesting that It was first described in the Russian literature in 1971. Now, I mentioned it was used in 1980s for spinal sonography in neonates, but actually in the Russian literature, it's there even before that. Bogin and his co-workers used it to perform lumbar puncture. In anesthesiology, it was first reported by Koch in 1980. Another individual that I have great respect for is Dr. Thomas Grau, who actually, with the limited resolution of the ultrasound images he had at the time, but still persevered and showed us actually how you could use ultrasound to perform these neuraxial blocks. And today ultrasound is used both in adults and children. This is Dr. Thomas Grau and a much younger me many years ago in Toronto, Dr. Thomas Grau from Germany. Also, it's very interesting to look at some of these images that are published in the literature. As you can see here, these structures have been labeled as ligamentum, flavum, vertebral body, etc. Now, it's very easy to criticize this quality of these images, but actually, at the time when you had, this is all that you had, shows that how visionary they were. They were able to identify at least where these structures were located, given the anatomical structures that they were able to see in the sonoanatomy. This is a report by Dr. Thomas Grau. Again, you can see he has very painstakingly labeled all the structures in this fuzzy gray and white image and how correct he was. And he used this in his clinical practice to perform central neuraxial blocks. Ultrasound imaging has come a long way. There's been remarkable improvements in ultrasound technology, both in hardware and software, so much so that today we are able to identify the images of the neuraxis with exceptional clarity. You can see here, and this was also as a prelude, Dr. Bernhard Moriggl showed you that this is indeed the paramedian sagittal oblique view of the lumbar spine, and I will come to that more in a short while. But I also like to show you the image to the right. This is actually a real-time image acquired using biplanar imaging, and on the left you have a 2D image, but on your right you have a biplanar image where you are not only seeing a sagittal view of the L4-5 intervertebral space, but you're also seeing a transverse view of the right hemi spine, if you may. You can see that because we are doing a right-sided paramedian scan, this is L4-5, you can see the right half of the thecal sac in a transverse view. So you can simultaneously see, concurrently see both the sagittal and the transverse view. If time permits, I will dwell more into this in the later part. Now, when you look at ultrasound for neuraxial blocks, I think before you go into it, I think it is important to look at some of the basic considerations. The spine is located at a depth, so therefore we use low-frequency ultrasound. Now, it's often described that low-frequency ultrasound has good penetration, but it lacks resolution at the depth. I think this statement is becoming more fuzzy at the moment because as ultrasound technology is improving and the software's processing of the data that we acquire is improving, I think you can get extremely good images even with low-frequency ultrasound. However, the bony structures that are in the path of your ultrasound beam, so the bones are actually a hindrance. They impede the passage of ultrasound, and therefore they cast a shadow. This creates a narrow acoustic window. So in the spinal architecture, if you may, it's important to understand where the crevices or the openings are through which you can drive the ultrasound beam or direct the ultrasound beam to see the neuraxial structures. So therefore, it is very important to know what these neuraxial osseous elements are so that you can find the narrow acoustic window that I've been alluding to. Now let's take a look at some of the osseous elements, and I think the previous speakers have already spoken at length. What we really are of interest is the vertebral arch, which, as you can see, the shape varies, as they have already alluded to. And if you look at this, it's more triangular and it's probably L5 level. You can see This is formed by parts of the pedicle, the lamina, and the lamina on the other side with the spinous process. Now, since we do epidurals and spinals from the posterior aspect, it is important to identify these structures when you are doing your neuraxial intervention. Also, the openings that allow you to perform these interventions and the ultrasound imaging is through the interlamellar spaces or through the intraspinous spaces. And as the previous speakers have already alluded to, these can vary from patient to patient and within the same patient per se. Now, as I mentioned, in my journey in really understanding the anatomy of the spine, when I started off on this journey, I really didn't know where to start. But when I thought about it, I felt that if the neuraxis is wrapped around by the bone, as you can see here in this rotating image, you can see that the neuraxial structures are actually wrapped around by bone, which have openings. So in order to really be able to accurately identify these openings, I need to know the bony structures first. So this is the basis of the water-based phantom that we initially used to study the osseous anatomy. It's very simple. You can create it in your laboratory, in your home, or in your hospital. You immerse it in a tub of water, like you see here in the plastic tub we have, and then you perform a scan in the transverse sagittal image plane and whatever planes that we are going to describe, and you will see how truly you can identify these structures, so much so that we found that every osseous element has a signature appearance, like everyone looks different from the other. Actually, the bony elements on an ultrasound also look very different. So this is a sequence of image where you can see the transverse view of the spinous process with the lamina on the side. This is just a transverse spinous process view, if you may. And this is a median sagittal view at the level of the spinous process. You can see the crescent-shaped spinous process with the interspinous space. As you go paramedian, the first structure you see is the lamina. This is how the lamina appear. They appear repeating patterns with a gap, which are the interlamellar spaces. And if you go further laterally, you start to see the articular processes which overlap to form the facet joints, and they are seen like a continuous wavy line. In contrast to the lamina, where there is an opening, at the level of the articular process, there are no openings. So you can easily understand that we are really aiming for the interlamellar space when you're performing an interlamellar intervention. Also, the water phantom is quite a useful tool because you can see through water. So if you, for the beginners and the novices, if you place a needle on the structure and you perform the scan, you can immediately validate what you are seeing on the ultrasound scan. And therefore, you can identify what a lamina looks like on a sagittal view and what an articular process looks like. If you go further laterally, you can see the transverse cuts or the axial cuts, transverse views of the spinous processes with their corresponding acoustic shadow. Also, ultrasonography of the spine, and in fact, for that matter, in most situations, is a case of recognizing patterns. A few patterns emerge in our early observations when we looked at some of these images. This is a transverse interspinous view. As you can see here, we are doing a transverse interspinous view. You can see here, it creates this osseous pattern. You can see the articular processes. In fact, the superior and inferior to form the facet joints here. You can see the transverse processes laterally. This is the spinal canal, and this is the posterior surface of the vertebral body, which is the very bright line here. So one of my residents said, oh, that looks like a cat's head. You can see here that there is some similarity when you look at the osseous pattern here. The ears of the cat actually represent the articular processes, and the whiskers, if you may, appear like the transverse processes. These are the level of the articular processes. To us, it appeared like they look more like the camel's hump. Sorry, these are the lamina. So you can see they look more like the horse heads, and the intervening area has gaps, which are the interlamellar spaces. Further laterally, you see the articular processes, which are more like the humps of the camel. So if you keep these sonographic patterns in mind and you perform a scan, before trying to look at the neuraxial structure, I would urge you first try and identify what osseous elements are you visualizing. That gives you an idea where your ultrasound plane is located. And as Dr. Sheah alluded to previously, that the ultrasound plane is actually only about 1 millimeter in thickness, if you may. So if your ultrasound beam is 1 millimeter to the right or the left, it may actually be insonating a different structure. Now let's take a look at in vivo. Let's put this together into in vivo in a patient or in a volunteer, as you can see here. We're doing a transverse scan. This is a transverse scan. This is a paramedian sagittal scan. The paramedian, because it is to the right of the median plane, which is the midline, and we are doing a paramedian sagittal scan. So the transverse scan is performed at the level of the spinous process. So this would be described as a transverse spinous process view. As you can see in this multiplanar view of the phantom, of osseous phantom, we are showing a CT. We've rendered it with the CT. You can see this is the spinous process. This is a sagittal view of the spinous process. We are not so familiar with the coronal view, but I often find the coronal view very informative when you're looking at anatomy, when you're looking at the spread of the drug. But anyway, that's for another day. When you do a transverse spinous process view, this is what you see. You can see a very bright spot here, which is indeed the spinous process. And anteriorly, you see a large acoustic shadow. Now, this acoustic shadow actually shows the outline of the lamina laterally and the spinous process posteriorly. Anteriorly, you have this large acoustic shadow, which is caused by this bone. As we said, it doesn't allow you to, the bone is impervious to bone. So you get this acoustic shadow. So this window would not be very good if you're looking for the neuraxis, but it'd be very good if you're looking for the midline. So the main application of this in clinical practice is to identify the midline. Now, in this individual, you could very well much as well be able to palpate the spinous process. But when you have an obese individual where the spinous process may be over here, then this osseous sonoanatomy can be very useful to identify the midline. As you can see in this correlative image, you can see this is the CT of this at the level of the spinous process. There's good correlation, and it indeed reflects what you see in vivo in an individual. Let's go a little bit further. You get a transverse interspinous view. Remember the cat's head. So we are doing a transverse interspinous. Now the spinous process is no longer there to obstruct your ultrasound plane. So you see the articular processes and the transverse process laterally. And thereby you can see now, there's no acoustic shadow. You're seeing the lateral elements, which are the articular processes. This is the posterior surface of the vertebral body, which now forms the anterior complex. This is indeed a complex that is made up of the posterior surface of the vertebral body, the posterior longitudinal ligament, and the anterior dura. And Professor Moriggl showed you that in this cadaver anatomic section. You can see the posterior dura very vividly and very clearly posteriorly. So now where would you use this sonographic image? Obviously, needless to say, you can look at the internal caliper, the scale on the right of the image. You can see, you can very well determine what the depth of this dura is in this individual. You can use the internal caliper in the ultrasound system to measure the depth. As you can see here, it correlates very well with the transverse interspinous view that we were talking about. And as Dr. Sheah mentioned, you can see that this shape of the spinal canal varies whether you are performing the scan higher up or lower down in the lumbar region. And this may have it may influence what we do in clinical practice. So therefore, you can see here we're measuring the depth to the dura. More importantly, you can also see that you can see the symmetry between either side. You can see the lateral elements are very symmetrically located, not exactly symmetrically, often as, again, the previous speakers have alluded to, absolute symmetry is not always the case. There is some variation, like The position of the spinous process in the midline are not absolutely in the midline. Some lateral deviation from the midline is the norm. Similarly, there may be some variation in the position of the articular processes, but in general, they are relatively symmetrical. When you see asymmetry in the position of the articular processes in the transverse interspinous view, it's a telltale sign that there may be some rotational defect in this individual. And very commonly, you can see it in scoliosis. So the sagittal view often provides, sagittal scan or the sagittal window often provides better view of the lumbar neuraxis. This is because there are fewer osseous elements to obstruct your ultrasound beam, and therefore the ultrasound beam is very easily projected onto the spinal canal and the meninges. But for completeness, we must talk a little bit about the spinous process window, the median spinous process window, which is right in the midline. You can see here, this is the sagittal window here in the median plane. You can see it as these crescent shaped, and the interspinous view here. Very rarely used in clinical practice, but for completeness, I think this is useful to describe this. Again, it's got a very good correlation to what you see in a CT or in an anatomical or an MRI image. It's the paramedian window that is often used in clinical practice for neuraxial blocks. We do a paramedian sagittal scan. It is important to identify what neuraxial structures you are seeing. As I showed you in the osseous water phantom that each osseous element, i.e. the lamina, the articular process, and the transverse process appear different. By performing the scan, you'll be able to recognize what level you are performing the sagittal scan. Also, when you perform a sagittal scan, you should have a routine. We often suggest that you perform start the scan from the sacrum, because the sacrum is a large flat surface, as you can see here in this water phantom. The first gap that you will see will be the lumbosacral junction, which is the lamina, the interlaminar space between the L5 and the S1. Once you recognize that, as you translate the transducer cephalad, you can identify L4, L3, L2, etc. And this is how you can count up to identify a given lumbar interspace. Also, another important anatomical feature of the lumbosacral junction or the L5-S1 gap is that the sacrum is usually directed posteriorly. As you can see here, the L5-S1 space is usually closer to the skin as opposed to the L4, L5, or the L3, L4 space. So it's often, for any given patient, it's usually a little more superficial than the other spaces that we often perform the intervention. As you can see here, this is the lamina of L5. This is the first sacral vertebra and the sacrum with a large acoustic shadow. In the acoustic window between the two, from a posterior to anterior in the L5-S1 gap, you can see the interlaminar ligaments, the ligamentum flavum, the posterior dura, and the hypoechoic ligament, the epidural space. And as the previous speakers have alluded to, the epidural space at L5-S1 is usually very narrow. Also, you can see the intrathecal space here and the anterior complex. Now, these structures may represent the Cauda equina. What you don't see here is actually this entire space is actually filled with the horse's tail, which is the equina, the Cauda equina. And therefore, it's not surprising that when you sometimes perform spinal injections or you do interventions, intrathecal injections through the L5-S1, you may find patients often may report paresthesia. So this is just to show you in more detail how the L5-S1 space appears. You can see here, this patient actually has had previous surgery, so there is some artifacts being created by the fibrous tissue, but you can see the sacrum here, the lamina of L5, and the interlaminar space. Also, if you note, the thecal sac here appears to be tapering, as opposed to when you look at it at L4, L5, it appears to be narrower than at the L4, L5. Nevertheless, the L5-S1 is a large interlaminar space and a large space. Once you have identified the lamina of L5, you can move the transducer cephalad, and we say you can count cephalad to identify the lamina of L3, 4, and 5. So this is the lamina view. We are paramedian, sagittal at the level of the lamina, but actually the optimal window for imaging the neuraxis, the paramedian laminar window, is actually not a true sagittal window. It is actually a paramedian, sagittal, but slightly oblique plane. So I often say to my fellows that there's a little twist in it. Now, there is no arithmetic number or degree that I can mention to you that you should apply, but it is often a case of dynamically you have to apply some degree of medial tilt till you can see the posterior dura and its other associated structure more clearly. It's not only a case of tilting the transducer. Often there is some degree of slide, and I will demonstrate that in the live demonstration later on. So this is the laminar view in this multiplanar view in this phantom. Again, it's a CT. And you can see this is the paramedian. It's a sagittal, and it's an oblique view of the lumbar L3, 4, and 5. You can see here the epidural space posterior is very clearly visualized. It's a few millimeters wide. You can see the very bright posterior dura. And you can also see the thecal sac anteriorly. And this is the thecal sac with some fine reflections here, which echoes from this may represent the Cauda equina and the anterior dura, the anterior complex, which is actually a composite image of the posterior surface of the vertebral body, or sometimes it could even be the intervertebral disc, the posterior longitudinal ligament, and the anterior dura. Now, I often say we really don't have much business here in this anterior epidural space unless you are a pain physician, maybe, but for anesthesiologists, we don't have any business here. So I often say we can club it all together as the anterior complex. Now, the anterior complex can be very useful. While we are often focused on the posterior complex to perform the intervention, actually the width of the anterior complex tells you how wide that interlamellar space is. So when you're performing a paramedian sagittal scan, look out for the anterior complex, because the anterior complex width often correlates well with the width of the interlamellar space and the acoustic window that you can achieve at that spot. As you see here, this is the L3, 4, 5 space, and you can see today with the ultrasound imaging technology we have, you can see exquisite images. And all it needs is just to insert a needle, and you can see the horse heads, and the intervening gaps are the interlamellar spaces with the ligamentum flavum, the epidural space, and the posterior dura. Okay, very recently there has been a publication by Dr. Conroy, Bloyet, Pauline McCartney, and McCarty from Canada. And they described this as an alternative approach, but actually, when I looked at the images, it's quite interesting. They set the patient up, they perform a scan, they place the transducer with a slight pivot. It's a paramedian sagittal scan, but the cranial end is pivoted towards the spinous process. I also remember actually reading a paper by Dr. Moriggl and their group using the same approach when they do paravertebral imaging. So this is nothing very new, really, but it's not a transverse scan. It's not a true paramedian sagittal scan. I can only say that this is a spinolaminar view because you are pivoting the medial end slightly, the cranial end slightly more medial, and this may circumvent the need for the medial orientation or the medial tilt that we require during the paramedian sagittal scan. And this is a real-time view for you. You can see the spinous process in this ultrasound window to your left. You can see the spinous process here. And on the caudal side, you can see the lamina. And in this intervening gap, you can see the posterior dura, the thick ligaments laterally, and the anterior complex with the thecal sac medially. This seems to be an interesting window, although I don't use it, but I'm becoming more of a fan of this and would like to try this out in my clinical practice. So what do you do with the articular process view? This is a view where you just perform the scan a little bit more lateral. You will see the continuous wavy line, which is the articular processes articulating with one another with no intervening gaps. Now, this can be of use to pain physicians who are interested in performing periarticular facet joint injections or identifying the articular processes before they turn it to a transverse view to identify the articular process. But as an anesthesiologist, when you perform neuraxial blocks, if you see this window or this morphological appearance, then it usually means your ultrasound beam is too lateral. It's telling you, please guide the needle, the beam more medially, because your lamina is more medially. So this is the camel hump sign that we often describe. And as I said, you can see it very clearly in this. They are all articulating, one on the superior and inferior, of the inferior from the vertebra above. And you can see here also the sacrum is actually directed a bit posteriorly, making the L5S1 closer to the skin. The transverse process view comes more laterally. You can see here. This is usually more relevant when we are performing scans for, say, lumbar plexus, or we want to scan the psoas or the lumbar nerve roots. And you can see here, this is a paramedian sagittal view at the level of the transverse process. It creates an axial view of these cuts of these transverse processes with the acoustic shadows. In the intervening gaps, you can see the large, thick psoas muscle. And the lumbar plexus is usually located in the posterior part of this muscle bundle here. They're located more in the posterior part. And since they are quite caudally directed, as Dr. Sheah alluded to, we've also demonstrated that once they exit the intervertebral foramina or the intervertebral canal, they actually direct it quite caudally. So when you perform the scan, it is required to do a slightly try and mimic that angle to see how the spinal nerves are actually following the psoas. You can see here these transverse processes and the lumbar plexus nerves within the. We will talk more about this when we talk about lumbar paravertebral scanning. This sonographic pattern has been described. We have described as the trident sign because of its similarity to the trident of Poseidon. And if you're an Indian like me, then it would relate to the Trishul of the Hindu god Shiva. Okay, now with this sonographic information, it is quite clear that you can perform a quite clear imaging of the transverse and sagittal view. While the transverse view is useful for identifying the midline, and probably in some individuals, you can also do the interspinous view and perform measurements and predict how deep the epidural space is or the thecal sac is. The paramedian window usually provides you better view of the neuraxis. So how do you use it in clinical practice? We can use it as a preview scan. So that means you do it as a pre-procedural scan. You do what you normally do with your landmarks and touch and feel, loss of resistance, but you perform a pre-procedural scan to supplant your landmark technique by identifying the midline. As you can see, I showed you the window where you can use it to identify the midline. You can accurately identifying a lumbar intervertebral space. Now, it is more accurate than palpation, but it's not 100% because there are times when you may have lumbarization or sacralization of the lumbar vertebra. So the true L5S1 may not always be an L5S1, but this happens in less than 10% of individuals. So I would say that you're accurate in 90% of the time. We can predict the depth to the dura and epidural spaces, and there's a lot of literature documenting the good correlation. You can also identify if there are rotational defects. Now, while this is important, we will discuss more about this when we discuss about scoliosis and how you do interventions in those patients. So don't miss out the webinar where we'll be talking about this. And Dr. Sheah will also be presenting a lot of useful information about scoliosis and other inflammatory disease in these cases. Also, you can find out the optimal site for needle insertion. Now, we say so because if you find that the ultrasound view of a given lumbar interspace is better than the other, then it's probably common sense to perform the intervention there, because this would because the neuraxis is better visualized, so this interspace is also probably much wider. Dr. Chin, again, he is from Canada and very well known in this area, also demonstrated that the visibility of the neuraxis can also be used to predict the ease or difficulty of the intervention. So in patients where ultrasound imaging is poor, these are patients where you'll also have a lot of difficulty performing neuraxial blocks. So it's telling you maybe you should use ultrasound in these patients as real time to facilitate success and rather than to have to perform multiple needle insertions. And overall, there are cumulative evidence which suggests that it improves the first pass success. So it offers some technical advantages. Now, it can never improve the success rate because, as I alluded to in my earlier slides, that the success rate of spinals and epidurals are about more than 95%. So in order to show statistical differences, you would need a large sample of patients, and I don't think such would be easily demonstrable in clinical practice. But certainly, published evidence is that it improved the first pass success, reduced technical complications during it, like it reduces postoperative headache, postoperative backache in the patients that have ultrasound guided. And there's also some evidence that has just emerged that when you use ultrasound guidance as a pre-procedural intervention, even as a pre-procedural intervention, it reduces the incidence of the possibility of bloody tap or aspirating blood to the catheter. Finally, you can also use it for real-time ultrasound guidance. And I will discuss more about this in my next presentation. So finally, the concluding remarks is today with the technology we have, it is very easily possible to perform accurate identification of of not only the osseous structures, but also the neuraxial structures. And this is facilitating us in performing the interventions of neuraxial blocks, whether you use it as a pre-interventional tool, like a pre-procedural scan, or you use it in real time. I think we will come to that in my next presentation. So please hold on. So if you want some references for future reading, these are some papers that I've been involved with. The first one is a review in anesthesiology. Second one is in the British Journal of Radiology, talking about the sonoanatomy of the spine. And you can get all the details that we have just discussed. Okay, with these few words, I'd like to end this. Now that we are able to perform neuraxial scanning, let's look at how we can use it to perform interventions. Now, I would at the very outset mention that neuraxial intervention using ultrasound is the most difficult ultrasound-guided intervention that you will ever perform. So you can't become an expert doing just 10, 15 blocks like you can do with brachial plexus. In fact, there are some blocks where you can say that you do one, you can teach one. But this is a learning process that will evolve over many years with experience. But by paying attention to what I'm going to say in the next 25, 30 minutes, I'm sure it'll cut your journey down to try and do this intervention more objectively, because we have learned it the hard way, and we've been doing this for many years now, more than 15 years, if you may. So again, I have no conflict of interest whatsoever relating to this presentation. Now, when you look at real-time ultrasound guidance for central neuraxial blocks, the question really is, okay, I don't deserve to stand next to them. So this is Corning and Beer, and as we alluded to, they actually described these epidurals and spinals. Now, I'm not really, I'm repeating this, I know that, but I like you to note that this really happened in the 1800s, in the late 1800s, okay? And subsequently, Mario Dogliotti, Achille Mario Dogliotti from Italy, actually, he is not an anesthesiologist. History says he was a surgeon. Now, it's interesting how surgeons were often involved with many of the innovations in anesthesiology. But at the time, anesthesia was an evolving specialist, and I believe this may be because surgeons who used to be doing everything. They used to give the anesthesia and probably do the surgery too at the same time. But anyway, let's move on. So this Dogliotti actually described the loss of resistance technique in 1933. So late 1800s and then 1933. So that's very relevant. It was only in the early 2000s when Dr. Thomas Grau actually published his experience in the use of ultrasound for epidurals and spinals, and I alluded to that in my previous presentation. This is Dr. Grau here. He's at the inaugural ISSPS in 2009 in this picture with some of the participants when he's conducting a workshop. Now let's take a look at real-time ultrasound-guided central neuraxial blocks. As I alluded to, Dogliotti described the loss of resistance technique in 1933. Now today, if you review the literature, there is actually a paucity of data. It's not as popular as performing ultrasound-guided peripheral nerve blocks. Nevertheless, several different techniques have been described in the literature, in the sitting position, lateral position, prone position, in plane, out of plane, non-dependent, dependent, etc., in needle insertion. So it may be fair to say there are no really optimal techniques described that we should be following. So the question is, why is real-time neuraxial block, central neuraxial block not as popular? I think it boils down again to the high success rate of landmark-based techniques. We seem to have accepted that 5% failure rate is an acceptable failure. And because landmark-based techniques offers low rate of complication. That's perfectly good. And it applies to all our clinical practice, whether you are in Asia, whether you're in South America, or whether you're in Africa or in the United States. Now, there are a lot of literature available today, and these are some of the meta-analysis that have been published, and in fact, some of them actually hot off the press. Now, when I collate this information for you, I may summarize saying that pre-procedural scans are more frequently performed because it accurately identifies a given lumbar interspace. It accurately identifies the midline. It allows to predict the depth to the dura. A pre-procedural scan in some literature indicates that it reduces the needle punctures and increases the first pass success. But there are also data which says that randomized and good quality data that says that it may not actually improve technical success or increase the first pass success. These are more relevant when you look at difficult patients. This is where the importance of ultrasound is, when you have a difficult spine or an obese. So if you're looking at a young individual, whether you do it landmark or with ultrasound, it probably does not make a difference. But when you are having a difficult spine, that's where it usually will make a difference. And as I alluded to, a pre-procedural scan prior to your landmark-based technique may reduce the incidence of bloody tap or even postpartum headache and backache. Now, this is another study comparing landmark versus pre-procedural ultrasound for neuraxial intervention as a systematic review. And these investigators in a non-obstetric population showed that actually it did not enhance the first pass success and increase the total time that it takes. So that means it doesn't improve success, but it actually increases the time. But they were very generous in mentioning that there is an increase which is statistically significant, but it clinically is not relevant. It's only about 4 or 5 minutes difference. Now, this is another study by Dr. El Sharkawi from the Cleveland Clinic. I wouldn't rate this study very high, but one of the results that came out of this randomized study comparing landmark versus real time, and in fact, this may be the first study which compared real time versus landmark, is that the operators rated these real time interventions more difficult than the landmark technique. That means ultrasound guided procedures were more difficult to perform. But then some of these operators had only done, as per their paper, had only done about 10 or had done a minimum of 10 before they embarked on the study. Now it's time for reflection. So I think some of the data goes either way. You can make a cause for using it. You may make a cause not for using. I'm not here to try and convince you that you should be using it all the time. But I would say, what would you do when you have a patient like so? Today is not the forum when we are going to say, what do you do when you have a scoliotic patient? We will do that in one of the later webinars, probably the third or fourth webinar. So stay tuned. But I think these are patients that are truly challenging in our clinical practice. We have described real-time ultrasound-guided epidurals with a single operator as early as 2009. The same technique's been adopted by Dr. Chin and their group to perform spinal injection, and they successfully showed in these two case reports that successful dural puncture was possible performing real-time ultrasound-guided spinal in these difficult patients. As you can see here, this looks like an elderly individual who's in the sitting position with some scoliosis present, and they performed the spinal injection after landmark base was difficult. As you can see here, Dr. Chin shows patient performing a paramedian sagittal scan with a spinal needle. It's in the sitting position, and the needle is from the dependent side. As I alluded to before, this is the spinolaminar view, and Dr. Conroy and their group used this report where they performed about 100, and the success rate was 97%. And they had I think, the first pass success rate in these cases. Real-time spinal in the prone position has also been described, the L5S1. I suspect these are mostly for pain procedures and with a high success rate. This study actually comprised of cadaveric dissection in five cadavers where they performed the L5 or the Taylor approach. This was described by Dr. Taylor or Mr. Taylor somewhere in the Midlands of England many years ago, performing spinals to the L5S1. And then in about 10 individuals, they performed real-time spinal injections or the Taylor approach in 10 individuals with great success. Needle guidance using the Sono GPS or needle GPS guided techniques have also been described in the literature. Now, while these appear to be useful, but they are very complex in the sense that you need extra equipment, extra special type of needles, longer spinal needles, because you need a magnetic sensor and a magnetic receiver for the magnetic field, and then you magnetize the tip. The needle is then advanced either in plane or out of plane, and you can guide it to the target. So whether you insert it out of plane or in plane. Now, today we don't really know where the role of this is, given the complexity that this may entail. But with experience, I'm sure Dr. Niazi and the rest have become very experienced with it. And as surgeons, as they are using navigation for many of their procedures, I think with experience, it can become easier. So you can see here, they're showing how you can perform out of plane here, as you can see, or an in-plane injection. So in order to make good sense of this, I would take you through some of the basic considerations, and then we can see how you can perform these neuraxial interventions using ultrasound. The first important factor is the choice of equipment. One shoe doesn't fit all. What do I mean by that? Now, you're imaging a spine, which is at a depth, and there's a very narrow acoustic window. So you need an equipment which has the muscle behind it. What I mean by that is you need an equipment that allows you optimizability. I'm not proposing any equipment one over the other. As I mentioned before, I have no financial interests or have any conflict of interest with anybody. But my advice to you is, if you are going to use ultrasound for neuraxial blocks, you need equipment with lots of muscle. You can't just take I would want of any other name. You can't just take any simple box and then fire it on and expect to see good images. And good images are paramount, because if you don't have good images, then you're as blind as a bat. So you don't really can't do these interventions without good equipment. Fortunately, with current advances in technology, some of the portable equipment that are available in day-to-day practice produce exceptionally good equipment. So my advice to you is to test them out and then choose what applies to you, your practice best. And of course, it'll also depend on how much money you are willing to spend. We've been very fortunate. We've been using some of these equipments as part of our research and equipment grants for more than 15 years now. And some of the images that you will see are actually from these high-end equipments. Now, ultrasound selection, the transducer selection I should have mentioned, is that today they are ultrasound transducer, low-frequency ultrasound transducer. As you can see, I put this whole array of low-frequency curved array transducers just to show you that they all vary in shapes and sizes, and they all vary in weight. I think the latter is very important because once you start doing neuraxial interventions, you will find that the weight of the transducer does matter, because very soon you will start to find that there are muscles in your hand that start to ache that you've never ever used before, and thus they are now getting tired, and the more tired you get, the more difficult the intervention becomes, so much so that it becomes a spiraling vicious cycle of more needle punctures and then failure. So in order to really be able to perform ultrasound-guided intervention, you have to have a very stable and strong non-dominant hand. So when my fellows join me, the first thing I do to them is I give them one of these medicine balls and I say, when you're not busy working, you should be doing this. Strengthen your non-dominant hand so that you can hold the transducer and make them these intrinsic muscle more stronger. Now, when you do interventions, we recommend or we advise you don't use any ultrasound gel. Why? As you can see, this is our setup. It has changed over the years, but it's pretty much the same. This is saline, and this is the alcohol hibitine that we use. It's colored so you don't confuse. And this is our equipment that is quite standard. Now, we don't use ultrasound gel because we don't know what ultrasound gel does to if it enters your neuraxis. I'm sure it won't do anything good, but I'm sure there's only bad thing ahead. This group, Dr. Pintarik, etc., and colleagues demonstrated in this article that in animal models, in piglets, that if any of this enters your neuraxis, it leads to a severe inflammatory response to the neuraxial spaces, as demonstrated by leukocytic infiltration and other features of inflammation. So I think if ultrasound gel does get to the meninges, it's not good. But having said that, there are authors that have published real-time interventions describing use of ultrasound, sterile ultrasound gel on the patient, and saying that we wipe this off at the point where the needle is inserted so that none of the gel gets in contact with the needle. But I would ask myself, would I do that the same to myself? I think the answer is probably no, because I would not want any of that gel to enter this sacrosanct space. I think that's a good word. It's a sacrosanct space that you don't want to breach unless you really have to, and more importantly, with anything that should not be there. Now, why is ultrasound gel used in these cases? Yes, when you don't use ultrasound gel, there is some degradation in the quality of the image. And given that you're doing it often in difficult patients, it also becomes quite difficult to visualize the image. We have found that just applying saline to the back and keeping the back moist does help. And then all you need to do is just maybe crank up the gain or the dynamic range in the time gain compensation in the area of interest, and you can usually overcome this. So we use normal saline as an alternative coupling agent, and over the years we've had no issues of using it. And the more you use it, the more you become familiar with it. Next is positioning, and ergonomics is very important. If you position a patient wrong or you place it in a slightly wrong ergonomics, it's actually failure from the get-go. So what do I mean by that? Now, as we alluded to, the paramedian sagittal oblique view gives you the best window. So this is the paramedian sagittal oblique window with the patient in the lateral position. Now, This is me. I'm right-handed, so I'm using my left hand to perform the scan. So I usually position all my patient in the left lateral position so that I can use my non-dominant hand to perform the scan, and then introduce my needle in plane from the caudal end towards the target interlamellar space. You can also position the patient supine, as you can sitting in the sitting position. This is, don't worry about the needle insertion here. We are doing a transverse scan, and the patient is in the lateral position. The machine is positioned right in front of me so that I can directly see the screen. When you're doing it in the sitting position, it's for a right hand dominant individual, we usually put it on the left hand side so that you can see the advancement of the needle in real time. When you do position a patient in the lateral decubitus position, it brings into play a non-dominant and a dominant side with respect to the midline and with respect to the neuraxis and the spinal canal. With a right-handed individual like me, I perform the scan with the left hand. So this is the position of the transducer, and the needle is inserted in plane from a caudocranial direction, like so. Through the ultrasound image I will show you, using my dominant hand. There are lots of literature showing that if you are a dominant, right-hand dominant individual and you use your left hand to perform any intervention, the chances of failure is very, very, very high. So that's, you don't need rocket science to show that. But nevertheless, so pay some attention to how you position your patient and where you, and how you perform the scan and the needle. As you can see here, under strict aseptic precaution, the patient is in the lateral. We are inserting the epidural needle in the caudal end of the transducer with the right paramedian sagittal oblique view. I will come to that. So the needle would appear somewhat like that, and we guide it to the interlamellar space. For an epidural, we would stop at the level of the ligamentum flavum, or somewhere once it's engaged. And then for a spinal, you advance it till you enter the thecal sac. Yes, it is possible to do it from the dependent side, because we are doing it from the non-dependent side because it is ergonomically much easier. You perform the scan, it's right at the eye level, and it makes your marrying the needle to the ultrasound plane much easier. When you do it from the dependent side, it becomes more ergonomically difficult for the intervention. Now, this is just to illustrate, if you are a right-handed individual and you position your patient in the right decubitus lateral position, you are now forced to use your left hand to perform the needle, unless you are a gymnast and you can position yourself in all kinds of ways to perform the intervention, but this would not be ideal. So pay some attention to how you position your patient in the lateral position with respect to your handedness. You can perform a transverse interspinous scan, like so. Although this is not very commonly used to perform in neuraxial intervention, it is our own experience, and there is some published work from China that now shows that the transverse interspinous scan can be quite useful. As you can see, this is the transverse interspinous view with the articular processes and the thecal sac in the midline. Dr. Liu and the colleagues from Wuhan in China showed that if you perform a transverse interspinous view and you introduce the needle from the non-dependent side, you can see here, this is the non-dependent side, it takes, it kind of circumvents the problem that right-handed or left-handedness does to you. Now, if the patient is not like so, then I could use, if I'm a right-handed or left-handed individual, I could still insert the needle with equal dexterity using this transverse scan. So the transverse interspinous view can be quite useful, as you can see here, illustrated by Dr. Liu, how you can perform the scan. He reported a first pass success of close to 95% and medial needle passes of around 2 to 3s. When you sit the patient up, it's also very comfortable for the patient, but it's not possible clinically to sit all patients up because they may have orthopedic fractures in the lower extremity, etc. And some of them are elderly, and it's quite difficult to sit them up. You can definitely, in those that you can sit them up, it is maybe desirable, and then you can perform a transverse scan or a sagittal scan depending on the approach that you would like to use, and we will come to that more. Aseptic precautions is paramount. Now that you are using a new equipment and you're going to use a new kind of procedure, it's very important to set up aseptic protocols in your department, because if you don't follow the set of protocols with respect to this, then there is a very high possibility that you may introduce infection into your patient just because you just did not realize that it happened. Okay, so here you can see we have prepared the transducer with a sterile sleeve. Now, while the sterile sleeves are useful for maintaining asepsis, but because they are now on the footprint of the transducer, it adds some complexity, because unless they are very securely and very well secured to the footprint, any crevices or any crumpling may induce artifacts in your ultrasound image. So it can be circumvented by applying a thin layer of ultrasound gel on the footprint of the transducer before you apply this plastic sleeve, and there are many in the market today. Well, you can see here, this is an aseptic precaution in a relatively good sized individual in the sitting position, and we place the machine to the left while my fellow is going to do the procedure. He is a right-handed individual. Okay, let's see how epidural catheterizations can be done. So we do a paramedian sagittal scan, as I alluded to, and the first important thing is to identify the landmark, which interspace you're performing this. So it starts by identifying the lumbosacral junction, as I mentioned to you in my previous talk, and then you count upwards to find the L3, 4, and 5. And depending on the best visibility of the neuraxial structure, as you can see here, this is probably L4, 5, and we can see the posterior dura very clearly, ligamentum flavum. We've chosen this as our target interlamellar space. Now, this is a epidural injection. So we now introduce the Tuohy needle after skin infiltration, just caudal to the transducer, and you advance it till the needle is engaged or in the interlamellar spaces and engaged at where this is the tip. And it's very important while you're inserting the needle, because now the plane is slightly oblique, it adds a degree of challenge to your dexterity and being able to visualize this. And this, I believe, is the main challenge for most beginners. And I have experienced that, but today I'm more experienced. So once you get the needle in plane, then you advance it till your needle tip is at the ligamentum flavum. The best place to bring the needle into plane is while the needle is within the erector spinae muscle. So you can change the orientation of the needle or the trajectory of the needle slightly more medial till it comes into the plane of your ultrasound beam. And once you have the needle in plane, don't move the transducer, and hopefully you can advance the needle in that till you get to the ligament flavum. You'd agree that ultrasound visibility of the epidural space is not as good as you would expect. So today, I would say that we still have to rely on loss of resistance till you to identify the epidural space. So Dogliotti still lives on. So now you can see with the needle engaged in the ligament flavum, we are now using a syringe which is primed with saline. This is a spring-loaded syringe. Now, this is a picture from many years ago. We don't do that anymore. I will tell you, just to show you what this does, then I will talk to you what you really need to do in the real world. So we attach it to the epidural needle, like so. As you can see, the plunger is retracted, and you see there are no locks or devices in this for obvious reasons. And then you advance the needle again in real time until you see forward movement of the plunger, and you see changes within the neuraxis. Now, this will loop around, but I like to just mention here that Dogliotti described this in 1933, but these are the first images of what really happens within the neuraxis when you inject normal saline for your loss of resistance. Needless to say, you wouldn't want to use air for your loss of resistance because you're using ultrasound. Look what happens to the dura when you insert the needle. When you get your at the moment of truth, if I may use that word. Oops, this has frozen. Okay, hopefully it'll keep looping. You can see that the dura becomes brighter. This is because of post-enhancement, and the whole thecal sac gets compressed. So now it is not surprising that when you sometimes do needle-through-needle CSE, dry taps are not uncommon, because your needle, the thecal needle, spinal needle that you insert to the Tuhi needle is not long enough, because the dura now has been displaced anteriorly. So using too much saline during a CSE is not advisable. And certainly this is for this reason, again, using a spring-loaded syringe is not very good, because you have no way of stopping it once you have that moment of truth and your loss of resistance occurs. So the simple way is to, if you hellbound on using it, then do not use too much saline. Just try 1 cc, because your objective is to detect loss of resistance, but not to inject the saline that you have in that loss of resistance syringe. Okay, let's move on. We are running out of time. Also, you can see here that the needle has been inserted in the CSE from quite a height. We are doing it from the non-dependent side, and you can see the needle come like so into the thecal sac, which is now a little bit compressed, and it's at a height of about 3 to 4 centimeters. You can see 1, 2, 3, 4 centimeters here. So if your CSF pressure is as low as 2 to 3 centimeters, you may find that there may be no CSF emerging from the end of the spinal needle. Besides, remember, the thecal sac is not round in all areas of the lumbar region. I think the shape of the thecal sac also varies from triangular, and it follows the shape of the spinal canal. So there may be lateral deflections of these needle, so therefore missing the true dura. Also, the needles we use today are of very low gauge, fine gauge, that is 25 and 27 gauge needles, which have very high internal resistance. So compounded by the height, from the height from which the needle is inserted, all are working in tandem to lead to dry taps. Nevertheless, in this case, it was not a dry tap. You successfully aspirate. And in fact, in some individual with the needle within the thecal sac, even if you aspirate, you may not always get CSF. But we've often performed in spinal injections in these cases, and we've had perfectly good success. And I will present a paper on that shortly. So you place the catheter and you perform, that's your epidural. So I think it's not important to use that spring-loaded syringe. Once you guide your needle to the ligamentum flavum, I would just place the transducer down and then use your traditional loss of resistance, and you'll find that your first pass success will be much higher. And this is true for whether you do it in the thoracic region or you do it in the spinal, you do it in the lumbar region, and we'll talk more about the thoracic another day. So what about spinal injections? This is the last part of my talk. As I alluded to, you can do spinal injections in the sitting or in the lateral position using real-time ultrasound guidance, as Dr. Chin has reported in this report. In fact, there was failure in Dr. Chin's report in those difficult patients using landmark. Therefore, they elected to use ultrasound. Also, I'd like to see you to see these images because it illustrates to you what the spinal needle looks like when it has actually entered the interlamellar space. And in this case, with this quality of image, it looks like the needle is actually in the epidural space. Now, this is not a 25 gauge spinal needle. This is indeed a 22 gauge pencil point spinal needle, which is much larger, and therefore you can see it much clearly. Seeing 25, 27 gauge needles are extremely difficult. So often you have to use surrogate markers like tissue movement to tell you where the needle exactly is. The needle is then advanced, and then you enter the thecal sac. And you look for your gold standard loss efflux of CSF. Now, while we think the efflux of CSF is always a simple matter and it would just gush out like you're doing an obstetric spinal, it may not always be true when you're doing an elderly individual or a dehydrated individual, a patient in the lateral position, and you're doing a paramedian sagittal oblique approach for your with an in-plane approach, like in this case for a spinal. You see, I have spoken many words, and it's only now that the CSF has actually effluxed. So the first drop of CSF takes quite a while before it actually emerges from the needle. Now, these are actually 25, 27 gauge spinal needles. As Dr. Sheah referred to this paper, we found that in a retrospective review of about 113 real-time spinal injections, ultrasound-guided spinal using the paramedian sagittal oblique view and the in-plane needle insertion with the patient in the lateral decubitus patient position in an elderly population, we found the incidence was as high as about 10%. In fact, slower CSF efflux can occur in about 14%. So the cumulative, you would see in every 1 in 4 individual that you perform real-time interventions, spinal intervention, that there is some problem with CSF efflux. Now, when I say slow, our cutoff time was 3 minutes. So in some cases, you had to wait as long as 2 minutes before I actually saw the CSF efflux. But are you that patient? Often you are not. So you may consider that the needle is actually not in the thecal sac. But if you look at it in the ultrasound, often you can detect that the needle is actually within the thecal sac. And in all these cases that we had dry tap, we performed the injection and we had a successful spinal anesthesia. So there have been many suggestions of trying and circumventing dry taps with various maneuvers. The sitting position surely may help. But while we think that the CSF efflux with the sitting position may be much faster and much quicker, I mean, that would be a logical way to think, but is it really so? We don't know. I think there is need for more research in this area, but just to show you that my fellow here is doing a preview scan. He's marked out his landmarks. He's done aseptic precaution. He's performing a right-sided paramedian sagittal oblique view. He's targeting one of the lower lumbar intervertebral spaces, local infiltration. We're now using an introducer needle here. The introducer needle actually acts as a surrogate because it's 20 gauge, often larger than the 25 and 27 gauge spinal needles. And they can actually offer you the trajectory at which you can introduce the needle, thus the introducer needle, because it would be shorter and therefore would be fall short of the interlamellar space. And then through it, you insert the spinal needle and then perform the spinal injection. This is just to illustrate to you that the CSF efflux after a spinal puncture with a 25 gauge spinal needle may not be as fast as you think, but it definitely appears to be faster. We've described an alternative approach called the transverse in-plane dependent, or the TIPD technique. It is a modification of the approach that Dr. Liu described. And this paper is currently under review. It just uses the transverse interspinous view. And then we perform the scan under aseptic precaution. The needle is now inserted from the non-dependent side, as you can see here. The needle is now inserted from a non-dependent through an introducer needle, whereas Dr. Liu introduced from the non-dependent side. We introduce it from the dependent side, beg your pardon. And while they use it for dexterity, we are trying to propose that this would be a better approach when you're looking at CSF efflux, because it's from the dependent side. And you can see here the patient is in the lateral position. We're performing a transverse scan. Also, it's important to remember that this needle is slightly offset from the midline because you don't want to introduce the needle too far lateral. So therefore, once you get your optimal view, you translate the transducer slightly more towards the non-dependent side, perform your local anesthetic infiltration, and then you insert the introducer needle. Aim the introducer needle towards the target. As you can see here, the introducer needle is now being inserted. It's now in the erector spinae muscle, and just anterior to this articular process and the facet joint complex. And then you aim for the center of the neuraxial thecal sac. And through this, we would then insert the spinal needle, and the spinal needle would obviously then puncture the thecal sac. And you can see here, we are now testing for the efflux of CSF before you inject the local anesthetic drug, as you would normally do. So it's important. The introducer is an important surrogate, because I think just because you're doing a spinal injection, one should not elect to use a larger gauge needle. I think it is good clinical practice to try and use a finer gauge needle, because these would lead to less postoperative complications, as we would expect. But however, there are times when it is not possible to do it with 25 gauge or 27 gauge spinal. Then surely that's how I practice my spinal injections. I often use lower, finer gauge needles first before I use a larger needle. This is a video just as interesting because it just shows you what dural tenting looks like when you're at the moment of truth and you're puncturing the dura. It's described all over the literature, so I thought you may find this interesting. Where you can see there's a slight tenting of the dura anteriorly before it bounces back. So this is just to show you the TIPD technique data. We've used it in a cohort of 30 patients. Successful dural puncture in 29 of the 30. Now, in the one that we failed, there was significant ossification of the interspinous ligaments. In fact, there were osteophytes that precluded to obtaining a good interspinous window. So therefore, just because you are wanting to do a TIPD technique, it doesn't mean that the anatomy would allow you to do so, because if you can't get the good TIPD window because of these various factors, then you're not going to be able to perform it. So there are some limitations. So therefore, being aware and being conversant with performing these interventions with either approach should form part of your armamentarium. CSF efflux times were about 22 seconds. I don't know what the normal time is, but this is what we described it as the first drop when it falls off the hub of the needle. That is CSF efflux time. So the Taylor technique is also described. It's performed through the L5-S1 gap, and as my previous colleagues alluded to, it's a large interlamellar space, and it's much closer to the skin, and you can perform an injection very easily through this. It's also described as the largest interlamellar space. I think I would like later on during the Q&A, Kenneth and Professor Moriggl also to comment a little bit as to the relative sizes of the interlamellar spaces, and is it that the L5-S1 is the largest, because it's often described in the literature. And it's often used even for landmark-based technique, but it's rarely used for central neuraxial blocks or in regional anesthesia when you're using it for anesthesia. And this is an important space, because when your chips are down and you have difficult patients, even with patients with previous instrumentation or previous inflammation, and as I will show you, that the L5-S1 seems to be rarely involved. I don't know why. Maybe this is God's grace for us anesthesiologists to be able to still perform spinal injections. I've often found it so. And you will find that the Harrington rods are never fixed on the sacrum, so the L5-S1 usually is open. So the prone position, L5-S1, can be performed, and I showed you these images previously. I won't go back into it. The L5-S1 gap is very easily identifiable, and then you can perform the scan. It's again, the L5-S1 space is much closer to the skin. It's just a paramedian sagittal window. It's being a wide space, it can very easily be used. You can also use the transverse view to perform, to identify the L5-S1. And now, in some individuals, you may not be able to do a paramedian sagittal scan, say for whether they have had laminectomies or they've had previous spine surgery for some reason. If you can't do so, then the transverse view is also an alternative approach. In this series of images, you will see this is the median sacral crest. So this is the sacrum, the sacroiliac joints, and the iliac crest. So this is the erector spinae muscle. As you go more proximally or cranially, you will see the sacral image disappears, shadow disappears, and you can see the anterior complex of the L5-S1 gap with the lateral pillars of the articular processes. So these also reflect that the L5-S1 space here with the thecal sac. And then you can, as you continue, you'll see the L5, the L4-5 interspace, the L4, L3-4, etc. We actually performed a study where, with this group from Thailand, where we compared landmark-based palpation to the primary outcome was to identify the L4 spinous process, compared to palpation, compared to ultrasound. When we used fluoroscopy as the gold standard, we found that ultrasound was more accurate than palpation, even with using the transverse scan. So this can be a useful alternative if you can't use the sagittal view. Furthermore, I think last few words is that when you have difficult spine, don't turn your back on the patient, because today there is technology available, and Kenneth Sheah has shown you that how well you can use the CT on an MRI, CT data to render these images in your PAC system, in your operating room, and plan your procedure and identify the best interlamellar space, as you can see here in this patient with ankylosing spondylitis in our operating theater. You can see we can identify the L5-S1 while the inflammatory process actually has occluded most of the other interlamellar spaces. So we plan the spinal through this, and this is a real-time ultrasound in this ankylosing spondylitic patient. You can see, voila, the L5-S1 just appears here, and the spinal was accurately performed through the L5-S1 interspace with success. However, when you perform, beg your pardon, maybe I've spoken too much. So when you perform these through the L5-S1 gap, because of the presence of the Cauda equina, paresthesia may be relatively higher in this individual. Also, dry tap may not be uncommon, because I'm in the belief that because the thecal sac narrows at the L5-S1, the spinal canal narrows at the L5-S1, and if the thecal sac is filled with the Cauda equina nerves, then when you place a needle at the L5-S1, there is very little CSF. And I also like to hear what the other speakers have to say with respect to this. Okay, with these few words, I hope I have illustrated to you, ladies and gentlemen, how you can use ultrasound to perform ultrasound imaging of the lumbar spine. I've also shown you how you can use it to perform real-time interventions. Remember that ultrasound can also be very useful as a pre-interventional tool to perform pre-procedural scan. So it's not always necessary to do a real-time scan, but I remember that when you do real-time interventions, dry taps are not uncommon. And if you're aware of this phenomenon, then, and you can confirm sonographically that your needle is in the thecal space, then injecting local anesthetic in these cases, like we did, would often lead to success. With these few words, I'd like to conclude. So now we will go into our Q&A. So I'd like to welcome our moderator, Dr. Louis Mock, to come in at this stage and moderate the Q&A for us, please.
All right, thanks, Dr. Karmakar, and all the other panelists for the very enlightening lectures. Now we're just going to go through a couple of questions, and I saw that some of them have been answered in the Q&A sessions, but perhaps the other members in the audience would like also to know some of the answers to these very intriguing questions. A couple of questions actually evolved around the incidence of the subdural injection. There are two questions related to that, both directed to Dr. Reina. The first one is whether the use of larger bore 16-gauge 2E needle in epidural might reduce the incidence of subdural injection. And the other is which approach, whether the paramedian approach or the midline approach is more likely to enter into subdural space. So I'm going to direct these questions to Dr. Reina.
The possibility of access to subdural space using a median or paramedian approach is similar, but mainly depend the large stent effect against the dural sac, but depend the advanced velocity the needle when you perform the epidural technique. It's very important and slow advance at last time of this technique to avoid this ten effect, this large ten effect, because the when you perform a puncture with spinal needles, bevel or pencil point spinal needle produce a simultaneous superimposed lesion on the dura mater and the arachnoid layer. But when you use the 2E needle and epidural needle with the rounded edges of the orifice, produce the piercing of the dura, but not the piercing the arachnoid layer at first time. When you advance the tip of the 2E needle, produce that detach and push of the arachnoid layer, giving origin to the subdural space. But using a paramedian or median approach is similar.
Thank you. So I gather that the approach didn't matter as long as the needle advancement is taken slowly and to prevent the absolutely prevent the tenting of the dura in the procedure. Thanks a lot, Dr. Reina. Another question to Dr. Reina and also Dr. Bernhard. It's in regards to the gap in the ligamentum flavum in the midline. So there is a member in the audience who would like to clarify whether this will confer an increased risk of a dural puncture because of the perceived lack of ligamentum flavum at the midline if the epidural is performed in the midline manner. Would a midline epidural insertion be more likely to lead to dural puncture because of the midline defect? What do Dr. Moriggl and Dr. Reina suggest?
Okay.
May I answer first?
Yes, of course.
Of clinical relevance, these gaps are only true in sense of having no loss of resistance if you are strictly in the median between those two parts of the ligament, and if the gaps are rather big, as I showed in one example on the right hand bottom side, then that may be clinically relevant. Otherwise, very often you're actually, practically speaking, not always quite in the median or in the middle between those two parts. So it may play a role, but I'm not aware of any study that says it has this or that clinical relevance. What's the truth that I mentioned during my lecture is that the more caudal you go, that means the more towards the sacrum, the less frequent are those gaps.
Mm.
And it's a quite different thing than in the thoracic spine. This will be shown in 2 weeks when you talk about thoracic region. Because we did, actually, to inform you,
I will go with the live demonstration.
the study on gaps was in my department. So we did all those specimens.
Okay, I will say I will go into the live demonstration.
Yep, thanks.
I just wanted hello.
Sorry, Brian and Manoj, could you just perhaps mute yourself? All right.
Sorry about that.
Thank you. So, all right. So let's now move on to Dr. Sheah. There's a question regarding the best technique to identify or to verify the positioning of epidural catheter. Can you perhaps suggest a modality of imaging that would be suitable to verify the position of an epidural catheter?
Okay, thank you. Assuming you're inserting the epidural catheter with fluoroscopy, it's important to record and mark where the tip of the catheter is at the end of the day, and of course confirm this with a bit of contrast injection. Keep that image because that's what we on the radiology side have to use for our comparison when you're doing follow-up studies. So currently my anesthetists usually send for MRI, and you usually should be able to make out the appearance of the tip of the catheter and follow it all the way up. Sometimes it's difficult, especially if there's scar tissue, for example, surrounding it can be difficult. But I think MRI is probably still the way to go. I think CT has too much radiation for the purposes of follow-up. Yeah. Right. Yeah, it's a good question. I think if you have the primary image, that the one that you use to at the final placement, and then we use that to compare with the MRI, then we can make a judgment of whether it's migrated or not.
Thank you. Thank you. And if Dr. Karmakar is around?
Yes, I'm around.
Yes.
Although you can't see me.
Yes,
technical issues.
There is a question in regards to ultrasound assessment of the lumbar spine. So this member of audience would like to know whether you would be able to identify lumbarization and sacralization of the lumbar spine.
Of course.
And how can you do so?
I think I will leave that question to Bernhard.
Okay, thanks. As I said, these variations in the lumbar sacral area, they're really relevant, especially because there is complete and partial and a lot of things that you have to know. The easiest thing is to start at the sacrum and look for the dorsal sacral foramina, okay? They're always visible with ultrasound. And it depends on how much of those foramina you count. You can estimate which is a sacralization or lumbarization. And if you look at both sides, you will always find in such cases there's more fusion on the one and less fusion on the other side. But it takes a lot of experience to differentiate the whole thing. So the answer is yes, it is possible, but not starting at the lumbar spine, start at the sacrum. Evaluate the dorsal surface of the sacrum very carefully, count foramina, and then you get your picture about those variations. And at the very last thing, I showed you one slide. I hope I didn't mention it. Some of you might have recognized that there was only 4 lumbar vertebrae, because the 5th was part of the sacrum. So, in addition to the very detailed analysis of the sacrum dorsal surface, you do at the second step from above downwards. That means from L1, which is easy because you can easily identify the 12th rib and know what is 12 and what is 1, and then count downwards, and those two things together give you a picture about sacralization. So it's a very It depends on your ability to differentiate osteostructures.
Kenneth, would you like to say something about it?
Yeah, sure. Certainly on the MRI or the CT scan, the way we number the lumbar vertebrae is with reference to C2. So while we do a block at the bottom for the lumbar spine MRI, usually what the techs will do for us is they will open up the whole field of view and scan right from the craniocervical junction so that we can see C2. And then we can count it all the way down to the last unfused segment. And that's how we tell. That's based on the MRI. For CT scan as well, that may be a bit variable. And Professor Bernhard is right. You have to then do your own analysis because it depends. You need to speak to your radiologist and establish some kind of understanding at an institutional level. So, for example, if you have a X-ray of the lumbar spine, you're not going to be able to count from C2. So you won't know what is the last unfused segment. You just assume that based on the last rib being at T12 level, whatever comes below T12 must be a lumbar vertebra. And so the way we would normally say is counting from the sacrum, the last unfused segment is L5, for example, or L4. Something like that. That's for the cases where we don't have a C2 vertebra to count down from.
Well, but there are variations in the T12 also, right?
Yeah, right.
Bernhard?
For example, the worst thing that you can get, and I have experienced that once in a patient that had a lumbar rib and a sacralization of a lumbar vertebra. So you're at the first step, you're completely confused because you start counting and then you say, oh, this is rib number 12. In fact, it was a long lumbar rib, which, by the way, happens more left than right. So it's sometimes challenging, but you have to have all those things in mind to not to get confused.
Thanks. Thanks for the answer. Maybe we'll just go for one more question if we have time. It is actually a question of general interest, and this participant would like to know, when do you teach your residents to use spinal ultrasound? Just because this is used to be considered one of the more advanced skills in the use of ultrasound. So do you have any practice preference or in your institution?
So the first thing, when I may answer, is you have to have an experienced guy on your side, otherwise you probably will never get much success. A second thing is, as shown in many institutions, a lot of people rely on plastic models of lumbar spine or the whole skeleton. This is a good thing to train, but it's nothing to prevent you from errors in the daily practice, because if you have the possibility, and I am in a happy situation to have real skeletons, best hundreds of them, to compare them, then you will get really experience in that field. But the most important thing is having somebody teaching you the right thing on the right patient in the right place.
Now, for all of you who are there, we've gone through a bit of information during the lectures, and I think it's fair to say that the cadaver anatomy, the CT, MRI, and the sonographic imaging was really put together a holistic approach to what we really aimed to do. And I think for the participant, I hope it was fruitful. Now, when you're looking at real-time scan for individuals, if you look at, put it here, it's okay, don't worry. When you look at ultrasound imaging, we're looking at the lumbar spine, as you can see here. Ranji, can you please? We are now imaging the lumbar spine. We place some landmark marks here. This is the iliac crest. These are the interspinous spaces. And as Bernhard mentioned, that these spinous processes may not always be tallied up one above the other. Now, later on, when we talk about ultrasound imaging in scoliosis, we will be talking about an SP line. That means a spinous process line. That means we will join these tip of the spinous process together so that we can then see the spinous process line. And any deviation from this usually suggests that there is an abnormality in the orientation, or there may be some rotation in the spine. This is not working, right?
It's working, huh?
Okay, good. Right, so put it on Mag view for me, please, just to make it easier. Mag view on the top right here. Yeah. Okay, so first of all, this is a curve array transducer. It is 5 to 1 megahertz. And for this demonstration, when I perform a transverse scan, it will represent the right side of this volunteer. This is his head end. This is obviously the back end. Okay, when I do a sagittal scan, the orientation marker will be pointing towards the head of the patient. So whenever you see a sagittal view, that'll be the head end. When you see a transverse view, it will be the right side of the patient. Now, so as I mentioned, you can do a midline median sagittal scan, but we tend to do this median sagittal scan because we find it's not very useful, and sometimes it's very difficult to acquire this because this may be because the spinous processes are not one below one over the other. Like you can see here, you can see a spinous process in the cranial end, but it's not really lined up against the other. So, and through the interspinous spaces, you can see the posterior dura and the anterior complex with the thecal sac in between. So I think the paramedian window is by far more commonly used. So in order to do a paramedian sagittal scan, we need to start from the sacrum. So we start at the level of the sacrum. You can see here at the, you can see on the, at the caudal end, you can see a large flat surface of the sacrum. And as I move more cranially, that's the sacrum. And then as you can see, the first lamina of L5. Now, can you please increase the depth for me a little bit? Okay, so here's your sacrum and the lumbosacral gap, which is the L5S1. And you see the lamina of L5 and then the lamina of L4. So you can count cranially and see that this is 3, 4, and 5. Okay, so this is 3, 4, and 5. And given this anatomy, I think 4, 5 is the PGS that I can see here. So I'm going to now optimize this view. Just move the focus up a touch, please. If you reduce the depth now, so we can get a bit more magnification. Okay, good. And then a little bit more depth, reduce it. Okay, so you can see the lamina of L4 and L5 very clearly. Actually, you can even see the epidural space outlines here. This is the narrow epidural space with the intervening fat-filled space, I suppose. The posterior dura behind. And in the thecal sac, you can also see there are some pulsating cauda equina. These are the white streaks of white lines, if you may. And that usually is the cauda equina nerves that are located here. These are the lamina here and the anterior complex, as you can see here. This anterior complex is very wide because actually you can freeze the image for me. And you can use the internal caliper to measure the width of the interlamellar space or the lip width of the anterior complex. And this will tell you how wide the given lumbar interspace is. However, this is a young man, he's a volunteer, and this is not the real scene when you're ducking and diving in the operating room and you're in the real world. I like that word, Kenneth. So you will find that patients have much narrower interlamellar spaces. They have much narrower acoustic windows. But a pearl for you is that look for the anterior complex, because the anterior, you can go live again, please. The anterior complex is a good indicator of whether there is a narrow space or not. And sometimes you may also see in the distal lamina that there may be some osteophytes. These are also seen when the interlaminar spaces are ossified. These osteophytes would extend into the interlaminar space, and therefore restricting the posterior complex width, and therefore the anterior complex width also will be reduced. So this is a normal individual. So from posterior to anterior, you can see the erector spinae muscle. You can see the lamina of L3, 4, and 5, and we've chosen 4, 5 because this is the space where I can see it best. The thecal sac is the anechoic space, posterior dura, the anterior complex, and the thecal sac. Okay, so here. Now somebody asked about how to detect the position of a catheter in the epidural space. Now, one of the ways that one may use is to use Doppler imaging after the injection of saline. Now, of course, it depends where the tip of the catheter is, but imagine your catheter is in this epidural window. Okay, you can see in this epidural space. If you inject normal saline through your catheter rapidly, you will see a kind of a blush of colors, as they often describe. That means it indicates a turbulent flow within the epidural space. So therefore, you can see it can be an indicator. It can also be used for caudal epidural injections and to locate the catheter. But again, the limitation is if your catheter tip is in the acoustic shadow, then it could lead to a false negative. So, however, people often ask me, how do you detect the needle that is in the thecal sac? In fact, after we published our report on dry taps, they said, oh, you checked it with the ultrasound, you did not aspirate the needle, then couldn't you have used Doppler? And I think the various researchers have also reported using Doppler imaging for determining the tip of a catheter within the thecal sac. I think there are some limitations, and this needs to be validated because when you inject drugs into the thecal sac, you inject it at a very low speed of injection. It's an obvious reason so that you don't get an unexpected high level of spread. Now, you're injecting slow into a fluid-filled space, so the flow is typically laminar, put it this way. And if there is laminar flow, it should not lead to any Doppler signal changes. Whereas, in order to see a Doppler change, you have to inject it relatively fast. In fact, Dr. Ben Sui did some work in a bench in some animals, and they showed that you need somewhere between 1 mil per minute of injection to see the Doppler signal. So that means you are injecting at a very fast rate of injection. So if your rate of injection is slow, then you may not see any Doppler change, although your needle is in the thecal sac. So bear that in mind. So aspiration would be the best test. If you don't, then seeing the needle within the thecal sac would be a good option. Next is, I'd like you to show you the adjacent anatomy. So we are now at the sacrum, lumbosacral junction, L45, 3, 4, 5. So now I'm going to move the transducer laterally, okay? So you can see here, these are the articular processes. These are the articular pillars that form the facet joints. And if you go further laterally, you can see the transverse processes and the acoustic shadows. You can increase the depth for me, please. You can see the transverse, the shadow of this psoas muscle. And he's got a large psoas muscle there, some hypo to hyperechoic shadow within the thick psoas muscle. There's more. And then you can see the retroperitoneal bowel and the motility of the bowel, I suppose. And you can see the psoas muscle in between the acoustic shadow. This we will use this more so for lumbar plexus injections and so on and so forth. However, if you are performing a neuraxial intervention and you see this structure, then it usually implies your transducer is a little bit too far lateral. You need to swing it a little bit more medial, like you see here. And once you move it more medially, you can see the neuraxial anatomy much more clearer. And so it is a paramedian, as you can see here. If I just did a true paramedian sagittal scan, you can see here the image is not as good. You're seeing only a narrow section of the thecal sac. It's probably only looking at the lateral sulcus of the thecal sac, if I may use that word. In contrast, when you watch what happens when I tilt it, you tilt it, and then there is some slide involved. So remember, it's not only a case of tilting, and as I mentioned, that there is no absolute number or degree. So you have to tilt it and then slide it till you get a good view of the posterior dura, and then you optimize your other machine-related your parameters till you get this good view. Now, you can freeze it there for me. So I don't have to hold it. And once you have positioned your transducer and you have steadied the image, Ranjit, can you please use the caliper and show how the needle would emerge? So we are going to insert the needle from a caudal direction here. You will see here, it would end up from the caudal end of the transducer. So it would emerge from there, and you guide it towards the dura. As you can see here, in this case, the arrow is now, the caliper is showing the direction in which the needle would be inserted. And so, okay, I would also like to show you the transverse view, which is can be useful. Again, as I mentioned, when we do the transverse scan, the orientation marker is pointing to the right of the patient, okay? So let's start from the sacrum. So we start from the sacrum here. Can I have some gel, please? Okay, here you go. So we're starting from the sacrum. Actually, you can see here. Right. So is the median sacral crest in the midline? Just put it there. You can see that's the median sacral crest. The sacroiliac joints are laterally, okay, and the iliac crest would be further out. So now we are going to move the transducer cephalad. You can see some, he has some, he has some anossification in the deficit in the sacrum itself. And then you go cephalad, you'll see the lumbosacral junction. This is the anterior complex. You can see the lateral elements, and the thecal sac would be in the middle, in the laterally. So that you can see the posterior dura here, and the dark space in the middle is your thecal sac. Okay. Now, if I go more proximally, you can see the L5. This is the spinous process of L5. As we said, you can use this to identify the midline and determine where the midline is located. You can go further up. So this is your L4, L5. So this is the transverse interspinous view that I alluded to. In fact, in this case, you can see in the dependent side, which is his left, you can see the facet joints also very nicely here, the articular processes, and possibly that's the facet joint with the hypoechoic gap there. So you can see the posterior dura and the anterior complex. Now, if I were to do a spinal injection here, we are obviously for dexterity, you can do it from this side too. So this is going to come from the non-dependent side. Okay, we prefer to do it from the dependent side so that your needle would emerge from here, and use an introducer needle, which would first come from the and then insert the introducer needle. It's like an aiming device, if you may. And then through that, you can insert your much thinner spinal needle. It punctures the dura, and you get your thecal sac. So I think a randomized study now, can you go live again? A randomized study now comparing a paramedian sagittal and a dependent TIPD, the transverse interspinous, a transverse in-plane dependent technique is underway. And we are looking at what the CSF efflux rates are from the non-dependent and the dependent side. I can always tell you the result. The CSF efflux is a much faster from the TIPD approach, from the dependent side, than from the non-dependent side. So the question, though, it begs the question, why don't we then all do spinals from the dependent side? Why aren't we taught to do spinals from paramedian spinals from the dependent side? Actually, there isn't any literature to say so. It only says that paramedian approach may be better than the median approach for the thoracic epidural. But for the lumbar approach, and especially in the elderly also, paramedian approach may be better because the midline may be ossified, that it may be narrowed, and many age-related changes may make midline approaches difficult. So paramedian approaches are desirable. So I think these are some of the facts. So I think ultrasound imaging using curved linear transducers, as you can see, with a good machine with where you can optimize the image appropriately, goes a long way in performing these scans. Secondly, next, finally, I'd like to show you the position of the L5S1. Okay, now we have L4, 5, and S1 here. Okay, can you please freeze the image for me? Okay, we have L4, L5, and S1 here. It also appears to me that the thecal sac is narrowing towards the L5S1. Now the question I have is, anyone, either Kenneth or Bernhard can answer this, is it real that the L5S1 is a much bigger space than L4, L5? One. Two is the CSF content at the L5S1 significantly less than at the L4, L5? I mean, Kenneth alluded to a lake. So does the lake get shallower as you go caudally? So can I hear your views, please?
Hey Manoj, it's Ken here. I'm not sure about the interlaminar measurements. Actually, I haven't gone and looked at it, but certainly from your scans, it certainly looks bigger. It'd be an interesting thing to just do some measurements there. It's really not that obvious on the CT scan or MRI that the L5S1 interlaminar space is that much bigger. And it could be positional as well, because you've got your patient in the fetal position, for example. That's one thing. And CSF spaces, I think because of the tapering of the spinal canal, the volume is probably going to be less at L5S1 versus higher up. But I'll leave it to Dr. Bernhard to illuminate.
Okay, thank you. So if you have a look at the lumbar spine from lateral, that means the spinous processes direct posteriorly, and you will recognize, if you do not get rid of your lordosis, the normal direction of the spinous processes in the upper part of the lumbar spine is more downwards. In the middle, it's more strictly posterior, and the secret is that the L5 spinous process, if you have a normal anatomy, a normal, non-changed, not pathological spine, in many cases, it points a little bit upwards. That is the reason why the space in normal people is often wider. This is not true in many people having alterations or even variations in the lumbosacral junction. So you can't say it's always the case, but what Manoj pointed out is a very good thing, saying if you have ossification, etc., like spondylosing ankylosing, it is almost always the case that those pathologies do not affect L5S1 or not as often as in the higher levels. That means I personally had the experience in a nurse when they called me in the pain department, and they said they tried to do an access to the spinal canal and they could not succeed at all. So they tried several times, and they said, "Do you have a solution?" I said, "Yes, I can try the L5S1," and it worked. So it's not the most important thing is not, is it wider? It is sometimes the only chance you have.
What's your views about the thecal sac and the CSF volumes?
I have no data on that. Logically speaking, I would say yes, it's less than in the upper part.
I think these are some interesting aspects of neuraxial blocks that we really don't have much data about. I must refer to a work by Professor Prats Galino from Barcelona and Dr. Sala Blanche, where they did in cadavers measure with segmentation, the volumes of CSF and soft tissue. But I think there is a limitation in the data because when the individual is deceased, usually the brain volume goes down. So most of the CSF from the lumbar spine usually dislocates to the brain. So, and I have often seen in cadaver models, when you do ultrasound guided spinal, the thecal sacs are quite narrow, and this may reflect that. So Kenneth, this really highlights that maybe this is an area that needs more research in terms of measurements and volumes, and it's quite simple to do in radiology because there's a wealth of data in the archives, and all you need is just somebody to sit and segment these as ASF and tissue, and then work out the various ratio. And finally is that the L5S1 always seems to be the savior and always saves the day. I don't know why, because the L5S1, whether it is inflammatory disease, rheumatoid arthritis, etc., seems to be the last space that usually gets occluded. Of course, if you can't see anything through the L5S1, more likely that you'll not be able to see anything through any other space. And in these difficult patients, for the registrants who are signing in here, is that when you anticipate a lot of difficulty, don't hesitate to request a high resolution CT, because the CTs can be done very quickly nowadays. And of course, there is some radiation involved, but it may help you to plan the interlamellar space through which you can best perform the intervention, whether it is L5S1, L3, 4, etc. It has allowed us to do so, and we think it is something that is available in most hospitals today and should become an integral part of your planning when you perform these procedures in real time. Okay, finally, I'd like to, we have, yes?
Mano,
anybody has to say?
Only to complete.
Yeah.
In relation to this study about the measure of cerebrospinal fluid, it was in patient, not in cadaver.
Okay.
And around the patient have around 5 milliliters per vertebral level at lumbar region. In general, in the old books, the total amount of cerebrospinal fluid is mentioned as 150 milliliters, but actual is more. At spinal level is 100 milliliter, and encephalic volume of cerebrospinal fluid add another 100 milliliter. In total, 250 milliliter is the total volume, encephalic and spinal.
Right. Okay. So, yeah, my apologies. I must have overlooked that. It's if it is in patients, then obviously that data, the ratios and all they have calculated shows that there are no differences. But given that the Cauda equina is so compact in the L5S1 and the thecal sac is narrowing, it would seem something that the CSF content would be lower. But maybe I'm wrong here. But again, we see a lot of paresthesia when you put a L5S1 and you put the needle in. The patient will often say, ouch, because you are more likely to touch the Cauda equina nerves at the L5S1, then at the L4, L5, I think so. Okay, finally, okay, this is an interesting area and you will find it useful. Now, for those of you who are still here with us, this is a matrix transducer. Unlike your normal linear transducer, which has 256 crystals or maybe more nowadays in the footprint, but this has in the thousands, this has like somewhere around 9,000 elements in the footprint, and everything is electronically steered. There are no moving parts. So this is can generate very high quality 3D data in real time, and therefore the refresh rates are much faster. Unlike the mechanical transducers, which are really big, and many of you may have seen in obstetrics, they use these big integrated mechanical transducers. But these are, there are no moving parts. It is just a little bit pretty much comparable to a linear transducer, if you may, a little bit heavier. It's a bit of wider footprint, but everything is electronically steered. Now this one is phased array, and so it acquires transverse, sagittal, and circumferential data at the same time. So we are now not going to use it for 3D without the coronal view, but we can show you how the biplanar view will be. So this is a 2D view of the lumbar spine of the same space of the L4, L5 that we saw before. Okay, so let me optimize this. Now, it's a very important principle with multiplanar imaging is that you have to make sure your 2D images are good. Because if your 2D images are not good, your volume will be poor, and therefore anything you render thereafter will be poor. So in this case, we are doing real-time biplanar imaging. So this is in 2D. How about you reduce the focus a little bit? Improve the refresh rate a little bit. Yeah, okay. I'll move it up a little bit. Okay, good. So here you can see the posterior dura. Can we go on to chroma, please? Now, we are using a little bit of a color 2D imaging here because it can improve the contrast visibility of the structures. Now, color imaging is not often used in anesthesiology because people are not aware what is the role of this 2D imaging. Actually, did you know your eyes are engineered for color, not for black and white? We can visualize color better and perceive colored images better, as opposed to lions and other hyenas who roam the wild in the dark. You are very poor in seeing things in the dark, but much better in the bright. So this actually you will often find if you change it to one of these color palettes, it gives you better visualization of the structures that I can often see, especially when the contrast of the images are poor. Now I think this is giving me a pretty good image of the intraspinous view. Okay. Now I'm going to as you can see, the images in the transverse view. Okay. Now I'm going to now switch it to the paramedian sagittal, and then we acquire the paramedian sagittal view. You can see here. Go to the sepia color. Oh, look at that. The dura is much better now. See. Okay. Now this is just a 2D view. I like you to see the number that you see on the top left end of the screen. It says 33 hertz. Now, for those of you who are not very familiar with what this means, is that this is the number of frames per second. Normally, when you see a movie, Hollywood movie, it usually cinematographic movie, it usually 24 frames per second. So anything above 24 will be similar to what you see in day-to-day TV, etc. Now, why this is important means the more resources you use, the slower the refresh rate will be. But you can see here, because this is using electronic steering and etc., and in real time, it's still being able to give us 33 frames per second. And this is perfectly conducive for doing real-time interventions. And we have done some studies with it, and we will be sharing our experience very soon. But I like to show you how you can use it to do biplanar imaging. Now, can you go on to, yeah, explain please? Now imagine the image to your left is our primary image, which is our sagittal image, okay? And then it has a line in the middle, which is actually the plane at which it is cutting the spinal view, okay? This is the, oh, don't freeze it. Now you can see that I'm doing a right paramedian sagittal oblique scan here. You can see the angle of my transducer. It's a little bit oblique so that I can insonate the dura good. Now we place that central line, just move the central line left and right a little bit. As you move the line, you see the image on your right changes because it is now changing the transverse view. But this is not the entire interspinous transverse view. It is just the hemi view of the transverse view on the right side. So on the image on your right, you can see the half of the thecal sac. Can you appreciate that? Just show them what I'm trying to describe. Yeah. So you can see that that is the dura, posterior dura, and you can see the epidural space posteriorly, and the anterior dura is more anteriorly. So that is the hemi view of the or the biplanar view. Let's go live again before we end it. So you can see here, this is the paramedian sagittal oblique, and you can see. So if you insert a needle in under real-time ultrasound guidance, you can use the image on your right to actually track the needle as it comes in the transverse view. So in essence, you can see the needle both in outer plane and in plane simultaneously. But the limitation is that the outer plane view will only appear when your needle touches that line that's delivering the transverse view. In fact, you can move the secondary plane. So just move the line left and right a little bit. So as you see, as the needle is approaching, you can move that plane left and you can move it right. Okay, so as the needle approaches the dura, you can slowly track it and insert it into the epidural space. Okay, so can you freeze it there? Okay, good. So this is a 6 X1 to 6. So this is our 6 megahertz. Today we have transducers. We are working with 14 megahertz X matrix transducers. The 14 megahertz transducers actually give you very high resolution images of the anatomy, and they are perfectly conducive for doing musculoskeletal, vascular imaging, etc. Originally designed for carotid scanning, but we have been using it for a host of different musculoskeletal anatomy interventions, etc. So with these few words, I think I would like to end this demonstration. I hope all of you had a great morning, afternoon, evening, if I may say. I think I surely learned a lot during these few hours, and to be able to share our experience with you was a true pleasure. Please join me in thanking the other faculty, particularly Bernhard and Miguel and Kenneth. You've been a star, and we really learned together, and I really appreciate you sharing all your knowledge and experience with us. With these few words, everybody, let's call it a day. I think you also need some rest. We also need some rest. And finally, before we sign out, thanks to our IT person behind the scene, Brian. He has done an excellent job. Thank you very much, all of you that have been involved. Adios. Bye-bye.
Bye-bye.
Thank you.